Hello, everyone. Welcome back to another day of our free NCLEX review session. And for those who are new to the channel, we are currently on day 46 of the 90 days of our free NCLEX sessions. And just to let you know, we tackle a variety of nursing topics with a focus on the medical surgical nursing concepts for now, but we'll be dealing with other concepts in nursing in the next few weeks. And so we are also inviting you to enroll to our comprehensive NCLEX review course at Stancoast NCLEX Coaching. And I'm happy to let you know that our complete NCLEX review course is valid for 6 months. And the course is structured so that you can finish all the necessary lessons within either 3 months or 12 weeks. And the actual duration depends on how many hours you can commit to studying each day. And so we really want to share some updates as well that we've made to our course content. The animated crash course has been expanded from 10 hours to 20 hours, and the recorded lectures have been extended from 100 hours to 200 hours. And you will be able to find so much of our resources, over 3,000 NCLEX-style questions and 20 hours of anime videos for those videos that we have shared with you. This is going to be important for your study as well. And kindly visit our website at www.stancoastnlexcoaching.com and make sure to click on the description box below so you will know more about us. And again, please don't forget to hit the like and also subscribe button, and also share this video to your friends who are preparing for the NCLEX. Now, today we'll be talking about the blood transfusion and also related nursing management, and we'll tackle on some NCLEX questions as well. Now, let's get started. Well, if you're going to ask why transfusions are needed, and specifically this is all about blood and the blood products, well, people will need the blood transfusion either because they probably lost blood, maybe due to some injury or illness, or maybe they have a medical condition that really affects their blood components. And so as we're going to talk about those components, this can include the packed red blood cells, the washed red blood cells, or the white blood cells. Fresh frozen plasma could be albumin. Clotting factors could be the cryoprecipitate or maybe platelets. And so we're going to talk here about the different types of transfusion. Well, the first one here is what we call as the standard donation. This is going to be done when someone receives blood from a compatible donor. Okay. Now, another is what we call is that autologous transfusion. So this is going to involve the collection of the blood and also storing of their own blood product before a surgery in order for them to use that, maybe after the procedure. And so it will be a lot safer because it can reduce the risk of reactions and also to some infections from the donor blood. Now, there's also what we call as intraoperative blood salvage. And this is going to happen when the blood lost during the surgery is going to be collected. They're going to clean it, and it will be returned to the patient during the same procedure. And it will also help reduce the need for the donor blood. And it is done within a very short time in order to maintain the effectiveness. Now, for those who just joined us, welcome, welcome, welcome. Now, let's take note about the different indications. Why the blood transfusion will be needed? Well, there are some instances wherein maybe there is excessive blood loss. And so the person here will probably need the packed red blood cells in order to replace the lost blood quickly. And maybe because there is anemia, and the blood transfusion will also depend on the level of the hemoglobin. Most often, less than 6, or let's say between 6 to 10 grams per deciliter. And again, the decision to transfuse this patient will be dependent into the severity of the anemia and also the manifestations. If the patient is severely symptomatic, then there's going to be a need to replace the red blood cells. Okay, not just about the hemoglobin. Please take note of that. Now, there's also going to be a need to transfuse the patient if in case they're going to have kidney failure. And as we know that in renal failure, the production of the red blood cells is somewhat suppressed. And I'm talking about the chronic type. Okay, please don't get confused here. We're talking about chronic renal failure, wherein there is a compromise in the production of the red blood cells because of what? Decreased erythropoietin release from the kidneys. All right, so there is going to be a decrease in the stimulation, decreased production of the red blood cells by the red bone marrow. Okay, decreased RBC production in the BM. Let me just shorten that as BM for the bone marrow. Again, welcome back. For those who just joined us, welcome. Hope you're going to stay with us up until the end of this lecture. Now, another indication for the blood transfusion could be possibly the coagulation factor deficiencies, such as in the case of hemophilia, and we talked about the hemophilia days ago. Again, the need to transfuse those deficient, we're going to transfuse them with the clotting factors. And here we're going to expect the infusion or transfusion of the fresh frozen plasma as well. Okay, FFP in cases of hemophilia when they are deficient in factor 8 and possibly the 9. Now, if in the case of a thrombocytopenia, we're also going to expect the transfusion of the platelets. If the patient is severely compromised, if there is a significant drop in their platelet count, and if they are really bleeding, then that decision will be made by the medical provider, and then we're going to get ready with transfusing that blood product rather. All right, I'm seeing All Things Home. Welcome to the class. This is the first time I've seen you, your name in the classroom, so welcome. All righty. Now, let's talk about another indication here, which is another hemophilia, which actually is repetitive here, so we're going to skip that. In a case of burns, extensive type of burns, or maybe hyperproteinemia, wherein there is going to there is a great need to replenish the albumin. Okay. So this is also a product that can be used to restore the protein levels in the blood. And remember about the role of the albumin, which is to maintain. Hello, Miss Virtuous Lady. Welcome back. Maintain the colloidal osmotic pressure. Don't forget about the albumin's role in the fluid balance inside the vascular compartment and also the interstitial spaces. Don't forget about the albumin. It will act as a sponge within the vascular compartment to prevent further leakage of the fluids into the interstitial spaces. And if you have not watched yet my video about that concept earlier, I think it was during the first weeks of the lectures, please watch that series, because I've talked about the role of the albumin in those concepts, especially in renal nursing. So I encourage you to rewatch if you still didn't get the role of the albumin. And so here we are going to expect the administration of albumin. We're gonna make sure that this is going to be replaced, as we know that there is a the possible leak of the albumin into the wounds, and so the body will be running out of the albumin itself. So we need to expect the transfusion or infusion of the albumin into this patient. Now, again, as a quick recap about this slide, in summary, we're gonna administer the blood transfusion. It could be of different forms or types. It could be a whole blood. It could be a specific blood component, maybe just a packed red blood cell, could be platelet, or it could be fresh frozen plasma, or just white blood cell. And again, these are going to be indicated for those conditions that we have mentioned already. Okay, now let's get to the next portion of our discussion here. And very important is the, what do you call this? Checking the patient for the different blood products. So we'll talk first about the platelets. Okay, so the platelet transfusion is a common blood product that we can give to those patients with symptomatic thrombocytopenia. And we definitely need to identify first, what is this platelet blood product? How much volume do we usually expect in a bag or a unit of a platelet? Usually the bag, it has about 200 to 300 mLs, okay, in each platelet bag. Now, talking about this kind of transfusion or blood product, this is something that will be given immediately as soon as we get the blood product from the blood bank, and we will talk a little bit more of that. So unlike the red blood cells, the platelets will not really require the ABO compatibility. Okay, you might be surprised by that kind of statement. The reason that the platelet will not really require the ABO compatibility because they lack the surface antigens that can cause blood type reaction. Okay, lack surface antigen that will cause blood type reaction. And so even though it is ideal to really screen the patient, make sure that there is ABO compatibility, but it's not really required. I mean, it is ideal, but not required because it's really hard to find a match for the platelet. And this is according to the literature, okay? Again, it is ideal to have ABO compatibility between the donor and the patient. However, it is not required. Again, the reason is the lack of the surface antigen in the platelet that could possibly cause the reactions. Now, talking about the administration about the platelets, this is going to be given within 15 to 30 minutes, okay? As soon as the blood product arrives in the patient's room, and as soon as everything has been set up already, the tubing has been set up, like the leukocyte filter, maybe it's already been primed already by the nurse, making sure that the verification has been done by the two nurses. And as soon as we get that blood product, we make sure that it is counter-checked and verified, and then we're going to have to infuse or transfuse that blood product in order to deliver and also maintain effectiveness of the platelet. Okay. Now, the patient will be checked on their vital signs before the transfusion is initiated, 15 minutes after the initiation, and also after the completion of the transfusion. Let me just correct that one. Okay. 30 minutes and wait a second. Okay, there you go. Going back. Whoops, what happened? So again, the patient will be checked on their vital signs before the initiation of the transfusion. They're going to be checked again 15 minutes after the initiation and then after the transfusion has been completed. Now, we will be talking about the next product here, which is the FFP, the fresh frozen plasma. And this is a product that is going to be used for those patients that are lacking the clotting factors, especially for the hemophiliacs. They lack the specific coagulation factors, 8 and 9 rather. Okay, so after the blood product has been thawed, okay, after it has been taken out from the blood bank in the laboratory department, it is going to be administered right away. And it is to be administered about 30 to 60 minutes. Within 30 to 60 minutes, of course, we're going to have to use the filter as well. And again, the patient will require here the ABO compatibility. So this is going to be required, ABO compatibility. So this is different compared to the platelet, okay? So in order to reduce any kind of reaction, all right? Now we'll talk about the white blood cell transfusion or the granulocyte. And this is something that I have not, I don't have an experience with the white blood cell or granulocyte. I've done so many red blood cell transfusion, fresh FFP, platelets, and the rest, but not this one. And this is a transfusion that is very rare, and that's the reason. And it is reserved for those patients that are severely immunocompromised. And the reason that it is rarely done, it's because of severe reactions that can occur to this patient, okay? So again, this is rarely done. White blood cell or a granulocyte type of transfusion. Now take a look into the volume here. It is going to be suspended in about 400 mLs of plasma. And the infusion time will be around 45 to 60 minutes. And the patient will also be required to, we're going to have to check their vital signs every 15 minutes because of the high risk. They're going to have to possibly have some immediate reaction. So that's why there is much more frequency in checking their vital signs and also making sure that we are evaluating them every now and then during the transfusion. Now, let's talk about the packed red blood cells. So this is also referred to as the washed RBCs, and they are going to be used for those patients that will be that has history of the severe transfusion reactions. Those have undergone the hematopoietic stem cell transplantation. And this kind of blood transfusion is gonna amount to 200 mLs per unit. Maybe in some preparations, it could be about 300 mLs. It can vary sometimes, but for most of the time, the 1 unit will equate to about 200 mLs. And we are talking about the packed red blood cells, all right? Now, this is going to be administered to about 2 to 4 hours. This is the standard range for the duration. And each hospital may have different protocols regarding the transfusion. Maybe there are going to be some protocols specific to those patients that may have history of congestive heart failure, that they might want to transfuse the blood maybe about 3 to 4 hours to decrease exacerbation of the CHF. And that's going to be really important for those people. Now, our patient here taking or getting the washed red blood cells or the packed red blood cells, we're also going to check their vital signs during or before the administration and also after the blood transfusion. And we know that there are some delayed reactions that may happen to our patient. So from time to time, we really need to check our patient if they feel okay, or if maybe they have some manifestations like back pain or any kind of delayed reaction. So we'll be monitoring our patient all throughout, okay? Now, we will talk about the pre-procedure steps. Before we're going to administer the blood products, it is very important that we're going to make sure that typing, cross-matching are done in order to prevent those incompatibilities. So here, we really need to make sure that we are following the protocols that are mandated by the institution that we are going to be working with. Make sure that we follow the guidelines. This is very important to decrease the incidence of the reactions, and make sure that we have the typing and cross-matching in order to determine the ABO and also the RH blood group, about the donor and also the recipient. And we're going to also check the compatibility, right, to prevent the adverse reaction. Now, the reason that we're going to do the type and cross-matching is to prevent the hemolytic transfusion reactions. That's the primary reason. Prevent hemolytic reactions. That is just one reason of many. And also to check if there is some issues with, let's say, antibodies, or maybe there are some issues with, let's say, infections. We also need to take a look into the screening of how extensive the screening has been done for this blood type. Okay, there are some blood products that are leukoreduced, irradiated, so we need to take a look into the specific orders of the medical provider as well. Now, taking a look into this table right here, and I'm sure that you are already familiar with the compatibilities, right? The antigen, the antibodies against, and what blood products they're going to be able to receive. And so just a quick review here regarding this. You will see that the blood types here, A, B, AB, O. So we have these different blood types classified based on the specific antigens present on the surface of the blood. So these are the specific antigens for each blood type. Of course, none for the type O. For the type A, of course, the red blood cells have an antigen A on their surface. Same thing with type B. They have that B antigen on their surface. And for type AB, they also have both antigens A and B on their surface. Now, for the antibodies against, we'll see here that in blood type A, take note, guys, that our antibodies are those proteins, right, that they're going to be produced by the immune system whenever they're going to recognize and when they are binding to the specific antigens, and they're going to mark them for destruction. Okay, again, the antibodies are those proteins that are going to be produced by the immune system that will help recognize and will bind to that specific antigen. Now, the antibodies against the antigens are going to be naturally present in the plasma of individuals based on their blood type. And so you will see here in blood type A, they have that antibody B, okay? So they're going to fight against that antigen, all right? Now for anti A, this is going to be found in the plasma of the type B blood. And so this is going to work against the antigen A. Now for the type O, actually there's none for the blood type AB. Okay, take note of that. There's no antibodies against either antigen A or antigen B. Now here, for the type O, take a look here. For the antibodies, the type O patient will have antibodies against A and also antibodies against B. All right, so take note of the special antibodies found in the O-type blood. Now, taking a look here with the compatibility for the blood type A, you will see here that the person can get either type A blood or blood type O donor, as we know that O is the universal donor, right? Whereas for type B blood person, they can only receive type B and also type O blood types. And for the type AB persons, they can receive blood from type A. They can also receive from type B, type AB, or type O, because they are known to be the universal recipient. And lastly, we have the type O person who can donate the blood to all blood types, but they can only receive blood type from type O donors, nobody else. Now, another consideration that we need to keep in mind is the Rh negative patients, especially those people. Okay, let me just write that down. Rh negative are those people born without the Rh antigen. Okay, let me rewrite that. Rh negative. And this is something that is usually overlooked. during the blood transfusion, which can potentially cause reaction, right? So again, those Rh negative people are born without the Rh antigen. Without Rh antigen in their RBC. So the result here is that they do not develop the antibodies unless there is sensitization. But once it occurs, the transfusion of, let's say, Rh positive blood. So for example, if a person who is Rh negative and for some reason they receive the Rh positive blood, this can now lead to a blood reaction. Okay, so this is something that you need to keep in mind, and this is going to be discussed further when you're gonna have the maternal nursing concepts. All righty, let's move on to the next section of our discussion. Here, you'll see a long list that I've already created for you. So when you're going to start, or let's say before you initiate the blood transfusion, you're gonna have to follow these guidelines. It's very important that you're gonna need to strictly abide the guidelines in order to prevent those incompatibilities and also reactions. So first things first is we are going to review the provider's order for the blood transfusion, make sure that it's stated clearly what type of blood product that will be transfused, the amount of the blood transfusion, how many units, and also the indication of the blood transfusion. These are the necessary elements in the blood transfusion order. Again, we want to make sure that there is a specific order for this blood transfusion according to the blood product, the volume, the indication, and maybe there's some more specifications. Maybe leukoreduce, wherein there is going to be a reduction of the white blood cells in the blood product, or maybe irradiation. So these are additional orders that can be given by the medical provider. Now, we also need to check on the current blood levels of our patient, their CBC, okay? We also need to check their coagulation studies, or maybe clotting factors. If they have any bleeding disorders, hemophilia A, hemophilia B, then definitely we need to see the result in their coagulation study. Clotting factors, I'm talking about here about the PT, PTT, INR. So these are necessary lab values that we need to look at before we're going to start transfusing our patient. Again, do this review first. Now, we're also going to need to have that ABO-RH compatibility. We need to make sure that there is cross-matching done before the blood transfusion occurs. And this is going to ensure that there is a correct administration. There is correct compatibility of the blood product as well. And then after that, we're going to have to obtain the patient's consent. Make sure that the medical provider has explained to them the risks and the benefits of the blood transfusion. Again, when you are going to obtain the consent, make sure that you have determined that the patient already talked with the medical provider. Make sure that they understand about the risks, the benefits, the indication, and also the adverse reaction of the blood transfusion. So this is going to be discussed as well. Adverse reaction will be discussed at length by the medical provider. Make sure that your patient, has the understanding, because if they're just signing the consent without understanding on any of these, then they're not really, they did not fully understand. Then the consent is somewhat like, hey, I'm just signing this, but I don't know anything. Make sure that they understand, all right? Because the more that they are aware about this procedure, about the possible adverse reactions, they're going to be able to help out in reporting those adverse reactions during the blood transfusion. Okay, so understanding about the process is very important before they're going to sign the consent. Okay, make sure that we have that. Now, we also need to explain the procedure to the patient. What's going to be the procedures that will be done and the sequence, so at least they will know, hey, okay, I'm supposed to do this time, so I should be watching for the adverse reactions myself while I'm getting the blood product. So they need to at least know the sequence. That's part of the education as well. So make sure that they understand that. Now, as far as the IV access, again, our standard IV size of the catheter would be around 18 gauge for the adults. At least 20 minimum size, and this is going to prevent hemolysis. Okay, now talking about the blood transfusion priming. Okay, so let me show you real quick in the next page. When we are going to prepare the blood transfusion product, make sure that we have already primed the tubing, which is basically the blood transfusion tubing. So you will notice that with this kind of tubing, there is that filter, okay? This is very distinct, and this is so different from a regular IV tubing. There should be that filter, that chamber. It's actually thicker compared to a regular chamber in a regular IV. And so this will trap all those extra leukocytes if we are giving them the type of, let's say, packed red blood cells. So this will reduce the introduction of the white blood cells, potentially. So before we're gonna have to start a transfusion, make sure that your saline, which is the 0.9% sodium chloride, is spiked. And make sure that you are priming the tubing all the way down, getting rid of those bubbles. Make sure that the bubbles are eliminated, terminated. And then you're going to have to open the clamp right here for the blood product and make sure that this is going to be filled at least midway in the chamber. You really don't want the chamber to be empty because, of course, if the blood product is the red blood cell, and if the chamber is somewhat kind of like very shallow, let me just draw this one right here. Supposing this is the chamber right here. Make sure that the level of this chamber is somewhat midway. And the reason for that is because if we're going to have to not place a significant amount midway in the chamber, those red blood cells can potentially split, right? If they're not going to fall into an area where there is a fluid. So they can potentially also hemolyze. So make sure that you have this area primed well. Make sure that there is enough volume of, let's say, normal saline, at least. So this will prevent some form of hemolysis. Okay, so that's about the priming. Make sure that we're going to use 0.9% sodium chloride. We're not going to use anything else, not even half normal saline, not D5 water, because those IV fluids can cause hemolysis of the red blood cells. Not even lactated ringers. We're only going to use 0.9%, nothing else. So let's go back into that previous screen right here. We're going to use that 0.9% sodium chloride. And also, we're going to have to possibly, but before we're going to do that, for example, when you are going to the blood bank and you are getting ready with the transfusions, of course, you're going to have to go do that. Or maybe you're going to send the nurse aide to grab the blood product from the blood bank. In some institutions, they will allow the nurse aides to get the blood product. In some institutions, they usually would like to have the RN get the blood product. It just depends. But once you have the blood product, make sure that you are inspecting the bag itself check for any discoloration, check for any excessive bubbling, or let's say cloudiness of the blood product. And this is very important. Okay, aside from just looking into the labels, because labels can sometimes be misleading. Maybe there's an error in the labeling. So you do need to do a physical check on the bag itself. All right, make sure you do your physical check, looking for those extra bubbles, cloudiness, and potentially the discoloration. So far, I have not encountered with these, but it's always ideal to check for these things. Now, why we need to do this? Well, if there is now discoloration, bubbling, cloudiness, this is a sign of bacterial contamination. These are signs of bacterial contamination, or there is already hemolysis in the blood product itself. Again, these three, discoloration, excessive bubbles, cloudiness, are signs that the blood product is contaminated by a bacteria, or there could be hemolysis. I know there should be screening, right, in the blood bank, but who knows, something happened, maybe something got missed. And so, yeah, there's always a need for us to do a physical check on the bag. You can see that. Now, there is also going to be a need possibly to use the blood warmer. What is this blood warmer? So this is what a blood warmer actually looks like. But let me go into the next page right here. So these are the different blood warmer products that are available in the market. The one that I've used in the past is this one. It looks kind of older than the rest of them. And so these are the different brands. And the reason for the patient to have a blood warmer is that maybe the patient has some kind of a problem, let's say cold agglutinin. So this is going to cause some issues in their blood, especially in cold temperatures. So again, the use of the blood warmer will be required, especially for those patients with cold agglutinin. Have you heard of this? Okay. These cold agglutinins are actually antibodies. They are antibodies that can cause the red blood cells to clump together, can cause clumping of the RBCs. They can cause the clumping of the red blood cells, especially in low temperatures. And with the clumping, it can also lead to hemolysis. So not all patients will be requiring the blood warmer, but there will be people that are already identified. Maybe if they had repetitive blood transfusions, maybe they had already an established data that they had some cold agglutinins, then for the remainder of their lives, if they're still going to need to have blood transfusions, then they're going to require the use of the blood warmer. Again, the reason that we're going to use this, it's because when this person has cold agglutinins, the antibodies will cause clumping of the red blood cells and will eventually cause hemolysis, especially at low temperature. And so the warming of the blood product is very important to allow safety during the blood transfusion. And so there will be recommendations on how warm the blood will be set up, okay? So it will be dependent on the medical provider. There is going to be a specific number of range that will be followed according to the institution's protocol, all right? Temperature setting is important, okay? Thank you. Blood warmer temperature. Yeah, I never learned about this in college as well. I only learned this when I started working in med-surg. There are so many things that you can learn in med-surg, especially when during my first year in med-surg. I used to work in the OR before that. That was my specialty, OR nursing, period. But when I decided to transition into med-surg, yeah, I was like in shock. I was basically like a nursing student once again, Again, that was the first time that I've seen that machine. I was like, what? I've never known about this, never read about this in the textbook, or maybe I just didn't read that part. But yeah, this is going to be a little bit more extensive. You're going to make sure that the tubing is going to be primed, because when you're going to use this kind of blood warmer, we're going to utilize a specific type of tubing that will match the machine. Okay, so there's also a chamber. There's going to be a leukocyte filter as well, but the tubing itself will be specific to the machine in order for it to be much more compatible. Okay, so there will be temperature setting, which is going to be recommended according to the institution policy. Now, let's talk about the transfusion vital signs assessment. This is very important, okay? We need to make sure that we have looked into the vital signs way before the blood product is going to be transfused. So take a look into the patient's vital signs, even maybe hours before the blood transfusion has been ordered. So take a look. Pay attention into the temperature, pay attention into the pulse rate, the blood pressure. Do you see any significant rise or any drop of those values? And then you also need to make sure to obtain a fresh set of vitals immediately before you start the blood transfusion. Let's say about 5 minutes before, not like an hour before. In my practice, I always make sure I have a fresh set of vitals as old as 5 minutes. I will not use anything older than 5 minutes, especially before the blood transfusion, always, because vital signs can change every minute, and I just want to keep myself safe during this procedure. And I'm very anal with the vital signs. Now, talking about the independent verification of the blood products, what is this? Well, in the ideal setting, and in most policies in the administration of blood products, this will require 2 nurses to independently check the blood product. So each of them will have to go through the medical order to see if there is really an order for that transfusion. Make sure that the 2 of them will independently check the blood product that is ordered, the volume, if there is specification about the duration of the transfusion, and also maybe specification about the irradiation and leukoreduced, and so many things else. So we have to make sure that both are doing this independently. And they need to check the consent as well. That is very important. Make sure that all the 2 of them will independently check to see, yeah, we have the consent from this patient and it is being witnessed by this person, the nurse. So make sure that both of them will do that as well. Now, after they're going to do an independent check, right before the administration, they're going to have to look into the label of the blood product and also take a look into the consent, make sure that they are checking into the patient's identifier, patient's name, birthday, make sure that the 2 of them will be doing the checking of the patient's identification. And again, going through the, let me write this down here because I forgot to put it in my slide. They need to check the unit number, which is specific to each blood bag, okay? Unit number of the blood product, the ABO compatibility, and also the RH compatibility. They need to go through that bag information, also the RH. So make sure that they're comparing the patient's blood type, RH type, and also comparing it with the donor type. Okay, RH type as well. What else? The unit number, ABO, RH, expiration date. This is very important. And also some specifics. Maybe there is an order to have an irradiated or leukoreduced type of blood product. Okay, so those are the things that will be verified. It is a very tedious procedure. I know it is very tedious procedure, and so many nurses can get tempted in rushing in the administration of the blood product, and that's why adverse reactions can happen, because of missing out in doing the strict procedure. And that is why adverse reactions can easily set in. Now, after that, we're going to have to start the blood transfusion. Let me clear it. So we're going to have to start the transfusion within 30 minutes after obtaining the blood product. And this is to also, reduce the risk of bacterial growth. Reduce the risk of bacterial growth. Especially that the temperature of the blood product has already been quite altered. It's no longer continuously refrigerated from the blood bank. And so make sure that we are making sure that we are administering the blood product within 30 minutes as soon as everything has been cleared, okay? So for example, guys, if there is such a delay in the administration of the blood product. So for example, yeah, you were hoping that you can immediately administer this one, right? Yeah, because you did not really anticipate of some other stuff. But in such cases wherein maybe the patient is a very hard stick and it probably would take more than 30 minutes to re-establish that IV access. So if you are going to think, yeah, maybe it will be a little bit kind of delayed type of a blood transfusion. So make sure that you're going to have to be mindful about some kind of a delay. So if in case you're anticipating that delay, make sure that you're going to return the blood product to the blood bank immediately before the 30-minute time frame runs out. Make sure that you return the blood product to the blood bank. Do not keep the blood product in the nursing floor's refrigerator, because those refrigerators are not intended to store the blood. Not even in the medication container, the refrigerator in the medication room, those are not designated refrigerators for the blood product. So immediately return the blood if there is going to be a delay in the blood transfusion. Okay, so please be mindful of that. Now, once the patient is ready, quite ready, we have done the vital signs, the verification has been completed, the tubing has been cleared from any bubbles, you've already primed everything, we're ready to go with a blood transfusion. So around this time, if you're the primary nurse, make sure that you're going to stay with the patient for the first 15 to 30 minutes during the transfusion. Okay, you are going to stay with the patient within the first 15 to 30 minutes. This is ideal. Okay, do not leave the patient unattended. Do not even replace yourself with a nurse aide. That's not within their scope to do the assessment. Okay, make sure the RN stays in the room, not a nurse aide, because they're not skilled. They don't have the same knowledge that we have in assessing those potential blood reactions. Patient's room. And the reason for that is to assess the patient for acute transfusion reaction. To assess acute transfusion reaction. And that's the reason that we cannot replace ourselves by putting somebody else like a nurse aide or the unassisted, not licensed personnel, let's say the CNA, where they're not supposed to do this kind of assessment. So you are going to stay with the patient for that whole duration. And again, the reason for that is to assess possible reactions, acute reactions, I should say, during the immediate period. Now, for older patients, this is very important, guys. For older patients, especially with those other comorbidities like heart failure, yeah, or maybe those patients that may have renal disease, renal failure, you got to be careful with them, guys, because they are going to experience fluid overload faster. So make sure that you are checking their kidney function, their fluid status, the circulation before you initiate the transfusion. Again, The reason for that, because they are prone to develop circulatory overload. Okay. Again, those patients that are older, and for those patients that have comorbidities such as congestive heart failure, for those patients that have renal failure, you got to be careful with these patients. Now, another thing is, if possible, okay, use blood products that are less than 1 week old. Maybe this sounds so ideal, right? Or too ideal, but this is recommended because at some point, this is just not possible. But if possible, we're going to have to use the blood products that are less than 1 week old. And there is a reason for that. Because the fresh blood products will have decreased levels of potassium, and also it will have lesser byproducts of cell breakdown. Okay, so what I'm trying to say here is that when the blood product has been stored in the blood bank for more than a week, okay, let me erase that. If the blood product is more than 1 week old, then possibly there is going to be high levels of potassium in the blood product. And this can lead to hyperkalemia in our patient, especially those who are at risk. It will not do any good for this patient. Okay, make sure that we're also monitoring their potassium level. And another is that with 1 week old blood, there's also an increase of other byproducts. And I'm talking about the breakdown of the cells. This will also lead to more reactions in our patients, especially the elderly. Okay, again, this is ideal, might not be possible, but something to consider, all right, especially for the older population. Now, let's talk this time about for those who just came into the classroom, these are the blood warmers that I talked about earlier. This is to prevent the hemolysis, the clumping of the red blood cells, especially if they have the cold agglutinins. We're going to have to get an order. Yes, I forgot to mention about the blood warmer. This is going to be ordered by the medical provider. We just cannot just grab this from the central supply. No, we need to obtain an order from the medical provider to use the blood warmer. Medical provider. And of course, the setting of the temperature will also be determined according to the hospital policy. Again, we just cannot use the blood warmer without the doctor's order. We need to have the doctor's order for this. Okie dokie. Now let's talk about the blood transfusion. Now, like I've said, when we are going to administer, especially during the intra procedure, okay, we're going to have to be at the bedside for the first 15 to 30 minutes. And this is to capture or to assess the patient of the possible complications, possible acute reactions. So what are we going to do here? We're going to have to do the assessment of the vital signs, especially for the older patients, assess their vitals every 15 minutes. And also with the duration of the blood transfusion, this is very critical for those who have congestive heart failure. Most often, the blood transfusion will be close to 3 to 4 hours. For me, I would rather administer the blood product in 3 to 4 hours. I rarely give the packed red blood cells less than 3 hours. And it's just in my practice. I've seen so many complications already. And so I just want to make sure that my patient will not have circulatory overload, and most of them have comorbidity. So I always avoid the 2-hour time frame. Only I will give the blood product in a 2-hour time frame. Let's say if they have rapid blood loss, maybe GI bleed, And if they don't have any other medical histories, then I'm gonna do the 2-hour infusion. But like I've said, if they have other histories, renal failure, heart failure, then I usually would keep my blood transfusion duration about 3 to 4 hours. Much safer. Okay. Another thing is that we're going to have to withhold the IV transfusion, IV infusion rather. So for example, if there is a simultaneous order to maintain infusion of, let's say, 75 mL normal saline continuously, and there's also a blood transfusion order, this is very critical, especially for the older patients. You need to communicate with the medical provider. Hey, do you want me to keep running the IV infusion, the normal IV fluids, while we are transfusing the blood? You need to consult with the medical provider if it's appropriate to withhold, because most of the times the patient that is older will end up with circulatory overload. So always consult the medical provider. Don't just assume that our patient will be able to tolerate it, and don't just assume that, yeah, it's ordered, I will do it anyways. No, you have to consider the old patients that you are treating, okay? Now for the procedure, after that blood transfusion has been completed, you're also going to have to check the vital signs. You're going to have to document the patient's responses. How are they feeling? You have to check the patient if they're developing any itching, or let's say pruritus, back pain, what else? Shortness of breath, or maybe some kind of difficulty of breathing. You have to check and ask your patient from time to time if they have these manifestations, because these are potential signs of transfusion reactions. Now, if everything goes well with your patient, I hope so, that no complications can occur. I always pray that when I'm dealing with a blood transfusion, everything goes well. Yeah, because within this time, anything can happen. You're gonna need to complete the paperwork. Have you seen the blood product, especially the bag? It is going to have that paperwork in it that is attached. Make sure that you complete that, the details. Usually it's in triplicate format. One for the blood bank, the other page will be for the patient's medical record, and the other one is just for extra, just in case. So again, this is going to be a triplicate document that is going to be attached into the bag. So make sure that you're going to fill in those information, let's say vital signs, the patient's responses, aside from documenting into the patient's medical record. So make sure you have that completion of the paperwork. Another thing is, as soon as you have done those stuff, you have to dispose the blood product bag and also the tubing according to the institution policy. So what we're going to use for is we are going to dispose them into the designated bins. Okay. And Oben, I will send you the link for the price of the program. Okay. All right. So these are the necessary, and I would say the most inclusive procedure that you should recall when you are going to be asked about the blood transfusion procedure. Okay. So maybe there's some other information, but probably would be kind of like unnecessary. But what I have in my presentations are the must-knows. Okay, kind of extensive, but these are must-knows when you are transfusing a patient. So let's go into the different complications. There will be some complications that you will probably encounter when you are dealing with a patient. And one of those complications is the acute hemolytic reaction. What is this? So this is going to occur immediately. It is sudden. Okay? God forbid that your patient will end up with acute hemolytic reaction. Okay? God forbid that they will have this acute hemolytic reaction, because everything will just be chaotic as soon as you notice that the patient will have this hemolytic reaction. So what is the cause of the acute hemolytic reaction? Well, basically, this is going to happen as a result to incompatibility. That is going to occur if there is incompatibility with the patient's blood type and also the donor's blood type. ABO incompatibility, ABORH, okay? So even a small amount of that blood that we try to transfuse for the patient, this can trigger the acute hemolytic reaction. Again, it is going to be sudden. The manifestations will show up readily, and it will be instantaneous. So what are you going to expect for this patient with acute hemolytic reaction? They're going to end up with the following: chills, fever, low back pain, tachycardia, flushing, low blood pressure, chest pain. Breathing is faster. Did I say breathing already? Yeah. Nausea. So these are the most common manifestations of acute hemolytic reaction. And also, when we are going to test the patient's urine, there is hemoglobinuria. And of course, this is going to be noticed only if the doctor will ask for a stat urine collection to determine if this has happened. So it will also be seen in the urine, hemoglobinuria. So again, this is caused by the breakdown of the red blood cells, the hemolysis. Okay, so what will be your nursing action around this time? Yes, you got to be quick around this time. What you're going to do is to stop the blood transfusion. That is the main thing that you should be doing once you suspect that the patient had developed the acute hemolytic reaction. Always do this. No exceptions. Stop the blood transfusion. Next is you're going to disconnect the tubing, the blood tubing. Make sure that you disconnect it from the patient's IV line or IV axis. You're going to have to save the tubing. Don't toss them. Keep them intact. Do not do anything else. After you disconnect the tubing, you're going to have to prevent any more incompatibility, right? So what are you going to do here? You're going to have to monitor their vital signs, check for any other manifestations, and also get ready with the administration of a 0.9 saline solution with a new IV tubing. Okay, that is why when you are going to initiate a blood transfusion, always get this ready ahead of time. Okay, so this is totally a separate setup. Okay, so make sure that you do this ahead of time just in case. So basically, guys, this is a separate setup compared to this one, because this is that one setup with one tubing, the leukocyte filter. So you're not going to use this anymore. You're going to disconnect the tip of this tubing. The saline that is being used will no longer be used. Okay, do not ever use the saline as soon as you suspect that the patient has acute hemolytic reaction, or whatever reaction I said. Okay, let me go back to that. Where are we? We are here. Okay, so acute hemolytic reaction, you got to make sure that you're going to set up another 0.9 sodium chloride with a new tubing. And then what's going to happen here is to check for their vital signs, continuously monitor the patient's vital sign, and check for their fluid balance. Okay, this is very important. And it doesn't end there. What are we going to do? We are going to send the blood tubing to the laboratory for more testing. Again, the patient will be manifesting so many manifestations here: hypotension, chest pain, tachypnea, tachycardia, low back pain. So you definitely need to call the medical provider for this type of reaction. Do not delay. Call MD. or the provider. Do not delay. And it will vary, right? According to the severity of the manifestations, you really need to keep your eyes peeled here. If the manifestations are so severe, maybe the patient is so hypotensive, they are now developing shock, or let's say they're developing chest pain, you have to treat this patient symptomatically. And possibly you're going to end up calling the rapid response as well. That is another nursing action that you can do. Call rapid response team. This is very important, guys. Notification of the rapid response team can save this patient's life. All right, let's move forward to the next reaction. Febrile reaction is also common, and this is going to occur within 2 hours of the transfusion. Occurs within 2 hours after the transfusion. So what you're going to notice here is an elevation of the patient's temperature. And this could be caused by the development of the antibodies by the host, the patient. And so it will be common to those patients that have received the blood transfusions for so many times. Common in patients who received multiple blood transfusions. BTs, shortening that one. Again, the febrile reaction is common for those patients who had several blood transfusions in the past because of the antibodies being developed against the transfused blood. Okay. Now, what are the manifestations for this patient with a febrile reaction? Well, of course, there is going to be fever, right? Fever, which is going to be an increment of 1 degree Celsius or greater compared to the baseline assessed temperature. Okay. Again, the fever will be spiking at least 1 degree Celsius above from the baseline temperature. There's also going to be chills. There's going to be flushing with the vasodilation. The patient will become hypotensive, and they're going to be tachycardic as well. So these are your chills, fever, flushing, hypotension, and tachycardia. Now, how are we going to deal with the febrile reaction? Well, according to the text, prevention is better than the cure. So what are we going to do? First thing is prevention. Okay? Before anything can happen, we need to prevent this type of complication. By how? We're going to use the leukocyte filter in order to remove those white blood cells that could trigger the response. Okay? We're going to use the leukocyte filter. Again, this is going to remove the white blood cells that can trigger the response. Now, even though you have done your diligent task of doing the prevention, in some cases it can still happen. If the reaction can occur into your patient, what you're going to do first is stop the blood transfusion. Do that first. And then we're going to have to monitor the patient's vital signs. We need to have baseline information before we can call the medical provider. And of course, I'll just insert it right here. Call MD. All right. And we're also going to have to get ready with the infusion of the normal saline solution in a new tubing. Okay. So once you have notified the medical provider, maybe there's going to be some new orders, maybe to administer an antipyretic medication or many other lab studies to follow up or evaluate the patient, then we're going to go ahead and do those things as well. We're going to have to carry out those orders. Now let's talk about another transfusion reaction, which is the allergic transfusion reaction. This is going to be a result to a hypersensitivity type of reaction. Due to the component of the transfused blood product, and it could be it could range from mild reaction, it could be severe. So what are those mild reactions? Actually, that's one right there, itching. So itching is a mild reaction. Hives can be another one. I don't like hives. I've had hives in the past due to an allergy to augmentin, and it's not fun, guys. There's that fear that eventually your airway will close. Laryngeal edema. No kidding. It's actually weird feeling. Bronchospasm. This is going to be the severe reaction. Bronchospasm. There's also swelling of the airway, laryngeal edema. Also, the patient will end up with severe hypotension and could also lead to the shock. So these are the severe manifestations right here. Bronchospasms, laryngeal edema, severe hypotension, and shock. So what are we going to do here as nurses? For the mild symptoms, again, start with stopping the blood transfusion. Make sure that you do that first. Stop the transfusion. And we're going to have to switch the patient's line. You're going to have to take that tubing out, disconnect it from the patient's IV line, and then we're going to have to switch it with another IV tubing. After we check the patient's vital signs, we're going to have to infuse the 0.9% sodium chloride. And also we're going to need to notify the medical provider. We're going to do that right away and wait for any possible orders. Those orders will include the administration of the antihistamine, maybe diphenhydramine IV for the mild reactions. But in cases wherein the patient will have the bronchospasm, laryngeal edema, you're going to give the epinephrine for the severe type. Again, this is going to what? Treat the bronchospasm. It will treat the laryngeal edema. And of course, it will also treat the patient's hypotension. Okay, remember about the epinephrine? It can cause vasoconstriction, but it can cause bronchodilation. Let me write those down. Can cause bronchodilation. Also will lead to vasoconstriction. So it will counteract the hypotension and also the shock by the vasoconstrictive effect of the medication. For the diphenhydramine, this will relieve the minor itching, hives, but it will not treat the bronchospasm. It will not. So for just the mild type, expect to administer diphenhydramine IV. Now, this time we're going to talk about, before I'm going to do that, there's some more. Let me erase this. Aside from the epinephrine for the severe reaction, there's more. Possibly, the medical provider will also order the corticosteroids. Corticosteroids. It could be in the form of Solucortef. This is going to reduce the inflammation. Reduce the inflammation where? Reduce the inflammation in the airways. Or it could be to reduce the inflammation in the skin. It can work in so many ways. Inflammation caused by the allergic reaction. It can cause, or it can treat the inflammation in the airways. It can also treat the inflammation in the skin caused by the allergic reactions. Now, aside from the steroids, we're also going to expect the administration of IV fluids. Why? It could be in a form of a bolus. And why we are administering a bolus? Well, it is going to be indicated for cases like shock, wherein the patient's blood pressure is going to be very low. So expect the administration of normal saline solution bolus. Okay. All righty. Let's go to the next reaction type. We'll talk about there's also supplemental oxygen, right, for hypoxemia. We're going to need to do that if in case the patient is hypoxemic, low O2 saturation. Let's talk about bacterial reaction. What is this? Well, the bacterial reaction can occur whenever the blood product has been contaminated by the bacteria. Again, this can occur even so with strict preparation of the blood product, even though the blood bank will do their stuff, but there's always going to be a room for error or maybe room for an infection. And so we will also have this kind of reaction. It is somewhat not really common, but again, if there is contamination of the blood product, then expect the bacterial reaction to occur. And what can happen if there is that bacterial reaction? Your patient will end up with the following: wheezing, shortness of breath, chest tightness. There are going to be some cyanosis. Our patient will have a drop in their blood pressure and shock as well. So you got to get ready with this kind of reaction. But this is not going to happen as instantaneously compared to the allergic type. It will be a little bit much more delayed compared to, okay? So this is a rapid onset for the allergic, whereas this one, it can happen also as an intermediate reaction, but not as rapid as the allergic type of reaction. Now, what are we going to do here for the bacterial type of reaction? There's many things that we can do here. We need to stop the blood transfusion right away. And of course, notify MD. Make sure you do that. If there's any kind of reaction, notify the medical provider right away. And we have to administer broad spectrum antibiotics as prescribed. As soon as we have notified the medical provider, they're going to give us those orders in order to initiate the therapy. And also, we're going to need to administer the IV fluids, normal saline solution. For example, if there is shock, hypotension, then that is indicated to treat the vasodilatory effect of the bacterial infection. We need to maintain adequate BP, tissue perfusion. The issue here is on the circulation. So we need to treat that by giving the patient IV fluid bolus to maintain adequate amount of blood, adequate amount of fluid circulating in the body to promote or maintain perfusion to the vital organs inside the body. Okay. If we're going to have a patient that has shortness of breath, or let's say wheezing, this can be treated symptomatically. Maybe O2 supplementation can be given to this patient. Another is that we will expect the collection of a blood culture. We are going to obtain the blood sample for the blood culture and send this to the lab as ordered immediately. So we will be able to identify the causative microorganism that contaminated the blood product. And of course, we need to identify correctly the microorganism to properly treat that. As soon as the blood cultures will come back, there's going to be a need to shift the medication from a broad spectrum antibiotics. If there is going to be a growth of that bacteria in the blood culture, it will be switched into a newer type of antibiotic accordingly. Okay. Now let's talk about another reaction here, which is the circulatory overload. And so far in my experience as a brand new med-surg way back, when was that, 20 years ago, as a med-surg, I've encountered this type of problems, especially in the elderly population. It's a circulatory overload, and this is mostly referred to as the TACO, okay? Circulatory overload, or what we call as the transfusion associated circulatory overload. So you can probably remember here Taco Bell. Okay. Yeah, I remember about that circulatory overload. I'll remember the Taco Bell burrito this time. So what is the reason of the circulatory overload? Well, this can happen when the administration of the blood product is too rapid. For example, if the recommended rate of the blood transfusion is 2 to 4 hours. So you got to stick with that kind of duration, right? However, let's consider the elderly population. If they have pre-existing condition, heart failure, renal failure, of course, you're not really going to stick with the 2 hours, right? Maybe this is way too fast for them. So I would usually administer them close to 4 hours, 3 hours, maybe 4 hours, but not exceeding 4 hours, to safeguard the patient from possible circulatory overload. Now, another reason is possibly the pre-existing conditions. Like I've said, the renal failure, congestive heart failure. So these are things that are conditions that you need to watch for. You got to consider this patient. Now, the overload can actually strain the heart and the lungs. So what can happen? The patient will go into what? The pulmonary edema. And I've already talked about this extensively in my previous lecture in the cardiovascular chapter. Go back into that lecture, look into that specific lecture so you will know more about the pulmonary edema. This is a medical emergency. Your patient will be really short of breath. So what are you going to note in this patient with the taco? Well, of course, the crackles, right? You will be hearing the coarse, long crackles when you're auscultating. There's going to be dyspnea, difficulty of breathing. There's also tachypnea, rapid breathing, coughing, which is going to be productive. And if they have the pulmonary edema, pink tinge sputum will be seen. Okay, what else? The patient will be anxious because they just don't know what's going on. I'm just here for the blood transfusion, and all of a sudden I'm having difficulty of breathing. Yeah, they will get anxious because they probably feel like, hey, I think I'm gonna die probably in the next hours. Yeah, that's quite true. This is going to be too much for the patient to experience. They will get anxious. What you're gonna see will be the JVD, the jugular venous distension. Yeah, look for that. Tachycardia is another one. There's also tachypnea, rapid breathing. And in severe cases, again, like I've said, the pulmonary edema. So your patient will not be able to tolerate just 45 degrees angle. They would be much more comfortable, not really comfortable, but at least they can catch their breath if they're sitting 90 degrees angle or maybe in orthopneic position. So yeah, what are you going to do here in this patient with the taco? Guys, the taco might be treated in the med-surg setting, but most often, probably not. You might need to send this patient to the critical care unit if they're not responding to the possible treatments. So what are the treatments? Well, if the circulatory overload is not that severe, you can either slow down the transfusion if it's not severe, right? If the manifestations are severe, stop the blood transfusion. Okay, that's why I put here according to severity of the manifestations. All right. If the patient's signs and symptoms are less severe, or let's say mild, you can slow down, notify the medical provider, notify MD. This is an abnormal assessment. Okay, stop the transfusion or slow down either. Now, what else are you going to do here? You're going to have to manage the circulatory overload. How are we going to do that? You're going to position the patient in upright position, 90 degrees, and make sure that their lower extremities should be lower than their heart. And this is to decrease venous return. All right. The leg should be in a dependent position, and we will be treating the patient's hypoxemia with the administration of oxygen. We could probably start with a nasal cannula, and then if they're not responding to that one, we can probably give them the mask, the simple mask, or maybe the non-rebreather. It depends on the severity of the patient's manifestation. And this is to maintain the oxygenation. Of course, that is a goal. And when we are notifying the medical provider, hey doctor, I'm just letting you know, my patient is in room 502. He came in with anemia, has a medical history of CHF, has renal failure. 5 minutes, or let's say 30 minutes into the transfusion, he started developing the shortness of breath. Oxygenation dropped. We already slowed down the transfusion, or let's say we have already stopped the blood transfusion. I have the oxygen on for this patient. Oxygen level improved from 90 degrees and 90% O2 sat. Now it improved to 95 on 2 liters. So you're going to do your S-bar to your doctor. Okay, make sure that you present the issue to your doctor. Make sure that this is organized. You have the situation, the background, your assessment, and also you have the recommendation. So as soon as you have talked to the medical provider, they're probably going to give you some more orders, right? Maybe there's going to be an order for stat x-ray, maybe a need for Lasix, which is the loop diuretic. Loop diuretic to get rid of the excess fluids. Wait. Loop diuretic, maybe a need for stat chest x-ray in order to follow up or evaluate if there is really a pulmonary edema going on, and maybe more labs. Maybe if the patient has a pre-existing congestive heart failure, maybe the doctor will order the BNP to check for the exacerbation of the CHF, and so many things else. There are so many possibilities that you will be, there's many orders that you can get from this conversation. So you better be ready to write down those verbal orders. Now, O2 supplement, diuretics is one, like I've said, loop diuretic to get rid of the excess fluids. In some cases, they might order the morphine, but you got to be cautious with this. Even though the morphine is intended to really decrease the anxiety, okay? This is to decrease the anxiety, but you got to be careful when you're administering this drug, because this can also lead to respiratory depression, which might cause more issue into our patient. So you might think about withholding this medication if the patient's case is so severe. All right. Again, it might be intended to diminish the patient's anxiety, but think about the oxygenation this time. You might need to withhold this drug. All right. Okay, so much for the TACO. This time we'll talk about TRALI. What is the TRALI? This is, we refer to as the transfusion-related acute lung injury. This is the worst, I should say, one of the worst transfusion reactions. Again, before we go to do that, I am inviting everyone to enroll to our NCLEX course at our website. Please check our website at www.stancoastnclexcoaching.com and also click the description box below. So you'll be able to know more about us, and I believe there's an email there, so you can communicate with our help support or the desk person to answer your queries as well. Okay, now let's move on about the TRALI. What is the TRALI? This is a rare but very serious complication. Rare but serious complication. This is a complication to the blood transfusion again. And what is this TRALI? I'm just going to write this down. It is an acute respiratory distress. It will cause the ARDS. Let me just simplify that. ARDS and also hypoxemia. Guys, Anticipate sending this patient to ICU, okay? If you find this patient with very severe respiratory manifestations, I would not keep this patient in the med surg. Send them to ICU as soon as the patient is stabilized, okay? As soon as you have notified the medical provider or notified the rapid response team, there's no way that you're going to keep this patient in the med surg. Send them to the ICU because they're going to need intubation and mechanical ventilation. As simple as that. Okay, but before we go do that, we're going to talk about their manifestations. What do you think are the manifestations? They're going to end up with respiratory distress, which is rapid onset. There's going to be tachypnea, severe drop in their O2 saturation. Take note of that. ARDS is no joke. Acute respiratory distress syndrome. Their breathing will be so labored. Their O2 saturation, again, will be very low, maybe in the 70s, 60s. There's going to be cyanosis because of the poor oxygenation to the peripheral system, the skin. Also, the blood pressure will go down severely, and the patient will end up with crackles. So, indicating about fluid accumulation in the lungs, and it will lead to respiratory failure. This is very sudden, very severe form of pulmonary problem. So what will be your nursing action here? Primarily, or initial nursing action. We're going to have to stop the blood transfusion immediately. Do not delay. Do not slow down the transfusion. Just stop it. Disconnect, okay? Disconnect the blood tubing from the patient. We're going to have to provide oxygen. Do not delay. Administer O2 right away. Once you assess that your patient is hypoxemic, we're going to have to prepare the patient for intubation. Yeah, prepare the patient for intubation, and also for continuous vital signs monitoring. You're going to have to connect your patient for continuous cardiac monitoring as well. Continuous cardiac monitoring. All right. And what else? We're going to have to notify the medical provider. These steps are actually going to be done simultaneously. You will not do this on your own, guys. When you are going to treat this patient, you're not just, hey, I can do it myself. I'm okay. I can call the doctor myself. I can connect the cardiac monitor with my patient. I can get the necessary equipment. No, you have to call for some help. There are so many nurses that will be available in the nursing floor. You call for help. Do not do this on your own, guys. Right? So many things can be accomplished in this very sudden scenario. You will have to ask for help because this is something that you just do on your own. This is impossible for you to do it on your own. Okay, so you're going to have to prioritize the patient's ABCs as well. If you're going to be asked in the NCLEX about the complication, you have to identify what is wrong with my patient. Is there a problem with the airway? Is there a problem with the breathing? Or is there a problem with the circulation? So you're going to answer the test question according to the issue. Is it airway? Is it breathing? Is it circulation? Now, other than the administration of the oxygen, attaching the patient to the cardiac monitor, continuous vital signs, checking, preparing for intubation, you also need to possibly get an order from the medical provider for a possible diuresis. This is very important. We need to mobilize the fluids. Mobilize the fluids. We're going to have to promote excretion of fluids from the lungs. This is one of the highlights in the treatment of TRALI. Mobilization of the fluids by the administration of the loop diuretic. All right. So what else? We're going to have to, as soon as everything kind of settles down, Make sure that you jot down all your, if you're the nurse in this scenario, I'm sure there is somebody that will be writing down. If there is the rapid response team, someone will be helping out, writing down those interventions that have been delivered to this patient. Or maybe you yourself, you'll be doing the documentation, just jotting down all those important actions that were provided, the time of the treatment, and also we're going to have to prepare the transport of this patient to the intensive care unit. Okay, again, there's no need for us to keep this patient in the med-surg because of the complexity in the care. If you're going to be assuming to be a hero of this patient, you're going to neglect the care for the rest of your patient. Don't do that. Okay, if you think that you're going to need more time for this patient, maybe it will eat your time, maybe entire 4 hours, this will not be safe for the other patients that you are taking care of. So don't keep this patient in the med-surg, send them to ICU. Of course, you're going to have to consult this to the medical provider and your charge nurse as well. Okay, now, what would be the prevention regarding the transfusion reactions? There's so many reactions that we need to keep an eye on. Well, one of those is the prevention. Make sure that there is compatibility and also testing, ABO-RH compatibility, appropriateness of the blood product, and make sure that you are recognizing, let me write these down. Erase. So I'll try to find a spot. What would be the key points regarding the reactions? So prevention is our priority. Ensure compatibility of the blood product. Don't forget about the ABO-RH compatibility. What else? We're going to have to recognize those early signs. Recognize signs and symptoms of reaction. And then we have to deal with the problem accordingly. Immediate action. This is going to be a very common kind of question in the NCLEX, especially in very rapid and a quick change in the patient's condition. This is quite a common question in the NCLEX. And after that, everything has settled down. We're going to have to educate the patient and family. All right. So teach them about what happened and what could be done in the future. Okay, those preventive measures that will be done if the patient will still require any more transfusion. All right, so I hope that you are learning something about the different complications here, the manifestations, the nursing actions. Again, these are very complex. Focus on this one if you don't know much about these complications. There's more I forgot to mention. So let me finish off this section right here. With the TRALI, aside from sending the patient to the ICU, diuresis, also there's going to be a significant restriction of fluids. You got to be cautious in administering IV fluids during the acute phase because of the possible pulmonary edema that can simultaneously occur in TRALI. Okay, again, don't forget about the transfusion-related acute lung injury. Question number 1, guys. A 20-year-old male patient presents to the emergency department after being, wait a minute, let me just charge my iPad real quick. Presents to the emergency department after being struck by a car. He has significant soft tissue injuries on his lower extremities and a laceration of the popliteal artery. His heart rate is 128 beats per minute and his blood pressure is 77/56 mmHg. After receiving multiple units of packed red blood cells, through a massive transfusion protocol, he develops tetany. Oh boy. So the question here, What is the expected? I forgot to put it down. Let me type it real quick. 841. 841. Wait a second. 841. What is the expected treatment for this patient? What is the high priority treatment for this patient? Okay. I asked questions some minutes ago. Okay. After receiving multiple units of packed red blood cells through a massive transfusion protocol, he develops tetany. What do you think would be the priority treatment of this patient? It looks like 2 of the treatments here are going to be performed. Okay. I know. You probably would be surprised here for the answer. Massive transfusion protocol. Take a look into the vital signs. The blood pressure is low, 77/56. And the patient is developing tetany. Don't forget about the tetany. This is going to be life-threatening as well. Hypotension. There's also an issue with hypocalcemia. What do you think? So you got to prioritize here, guys, because the other problem might be worse than the other one. Okay? You got to pinpoint the main issue of the scenario. What is the main issue here? You'll see there are many issues here. There's tachycardia. There's also low blood pressure. There's also tetany. And tetany, that can possibly cause something else. What do you think would that be? Let's try to eliminate one at a time. Fresh frozen plasma. Well, the fresh frozen plasma is going to replace the clotting factors. Okay, let's talk about this one. Replaces the clotting factors. It can, but this will not deal with what? It will not treating hypotension and not treating hypocalcemia. So we are going to eliminate that one because our issue is on hypotension and hypocalcemia. Eliminate that one. What about letter B, intravenous potassium? Take note that the patient has received multiple packed red blood cells. And the more red blood cells that they're getting, typically this can cause hyperkalemia. So we don't need to administer IV potassium. Hyperkalemia due to multiple transfusions. All right, here we go. We have the last two. Who's the winner? Who is the winner of the two here? Let's talk about the problem. Hypocalcemia, especially tetany. This is a life-threatening condition which can cause spasms in the airway. Do you like this one? Bronchospasms? No, we don't want this. This is an airway issue. It is an airway issue once they develop the tetany due to severe hypocalcemia. You gotta keep the airway patent. So what are we gonna do to address this one? We're gonna have to administer calcium gluconate. Calcium gluconate IV. All right, this is to treat the hypocalcemia caused by the multiple transfusion. Why there is hypocalcemia in multiple transfusion? Why? Remember about the citrate in the blood product? This can bind to the calcium. Citrate in the blood product can bind into the RBCs. Actually, not RBC, but the calcium. It can bind into the calcium, and so it will be eliminated in the body and subsequently will cause tetany. All right. So deal first with a possibility in the airway. Okay. Even though the blood pressure is low, it is already known, right? But again, our concern here is the possibility of the airway bronchospasm. Normal saline bolus, I know this is also important, but we're going to have to prioritize our patient with a tetany, especially if they have impending bronchospasm. This can follow after D. So quite very critical type of choices here. You have to prioritize first our airway. Now moving on to the next question. A 52-year-old man with chronic myelocytic leukemia receives a blood transfusion. During the infusion, he develops fevers, chills, and malaise. His blood pressure is 104/68 mmHg. Heart rate is 88 beats per minute. The respiratory rate is 18 breaths per minute. And temperature 38.4 or 101.3 Fahrenheit. What is the appropriate management for this condition? Is it A, intravenous acetaminophen, B, IV diphenhydramine, C, stop the transfusion completely, and D, intravenous hydrocortisone? Again, our patient has an issue with the chronic myelocytic leukemia, receiving the blood transfusion. Now he's developing the fevers, chills, malaise, blood pressure, not bad. Heart rate of 88, respiratory rate, seems okay. But the patient has fever, 38.4 degrees Celsius. So what would be your choice here? I'm seeing lots of C's. That's a good sign. You are correct. Congratulations. Answer is letter C. Stop the transfusion completely. Okay, let's tackle letter A first. If you had answered letter A, intravenous acetaminophen, that is already incorrect because you are only alleviating the symptoms. Only alleviates the symptoms, or the symptom rather, but does not address the underlying cause. Does not address the underlying cause. Okay, so eliminating letter A this time. What about letter B? Intravenous diphenhydramine, which is the antihistamine. This is also going to be incorrect. It is going to be helpful in the allergic component of the scenario, right? But it does not address the primary but it's not going to be the primary intervention. Not the primary intervention. You're only treating the symptom. So, what about letter D, intravenous hydrocortisone? What do you think about the administration of hydrocortisone? This is going to be used for an allergic type of reaction, but stopping the transfusion would be much more of a higher priority, okay? Can treat allergic reaction. But do you see allergic reaction here, guys? Possibly the chills, the fever, but looking into the vital signs, they seem to be not really coincide with the allergic reaction. So our best step right now is to what? Stop the transfusion completely. We need to do that as a primary nursing action, okay? Make sure that you are not allowing any more blood product to go inside the patient's system. This is going to be the immediate nursing action to do with a febrile type of reaction. First intervention in treating febrile reaction. We're dealing with a febrile reaction, not allergic reaction. Okay? So we are eliminating hydrocortisone and diphenhydramine because these are intended for allergic type of reaction. And A, yeah, this can be done later on after we have stopped the blood transfusion. We need to stop the transfusion first, notify the medical provider, and we're going to get the order for the IV acetaminophen. All right? Prioritize those interventions that can lessen injury or interventions that can prevent more harm to our patient, which is immediate cessation of the blood transfusion. Now let's talk about number 3. A nurse is administering packed red blood cells to a client. The nurse should first, A, discontinue the IV catheter if a blood transfusion reaction occurs. B, administer the packed red blood cells through a percutaneously inserted central catheter lined with a 20-gauge needle. C, flush the red blood cells with 5% dextrose and half normal saline solution. And letter D, stay with the client during the first 15 minutes of infusion. So this is a general nursing question. A nurse is administering packed red blood cells to a client. The nurse should first. Is it A? Is it B? Is it C or D? Take your pick. I don't know if there's such a delay with streaming, but I don't see any answers yet. So let's take a look into letter A. Discontinue the IV catheter if a blood transfusion reaction occurs. Did I mention that one? Discontinuing? Well, there's no need to discontinue the IV catheter because this is going to be necessary for the administration of medication to treat the reaction. Do not discontinue the IV catheter. You need the IV access. Discontinue the IV cath. You will need that IV access to administer those medications. Eliminate that one. What about letter B? Administer the packed red blood cells through a percutaneously inserted central catheter line with a 20-gauge needle. This is incorrect. The patient should have, what is this, with a gauge 20 needle? Actually, this is also incorrect. This is going to avoid a much larger, comparing it. So this is also not recommended. even though a 20 seems to be appropriate, but it said here, inserted central line catheter with a 20. I don't think so. That's not going to be appropriate. Central line with a 20 gauge needle. We're not going to use any needle on a central line catheter. Eliminate that one. What about letter C? Flush packed red blood cells with a 5% half normal saline. Supposedly it should be 0.9% sodium chloride. We are not going to use any other IV type. Always plain normal saline solution. Okay, the 0.9%. Do not use anything else. Anything with the dextrose can lead to hemolysis, also clumping of the red blood cells. Not utilizing that one. So we are going to be tied with letter D. Stay with the client during the first 15 minutes of infusion. Okay, and the reason for the letter D is to assess the patient for immediate transfusion reactions. Okay, we're going to have to assess the patient for those rapid onset transfusion reactions. That's why we need to stay in the patient's room and frequently assessing. Okay, let's move on to number 4. Which safety measures would be most important to implement when caring for a client who is receiving 2 units of packed red blood cells? Again, which safety measures would be most important to implement when caring for a client who is receiving 2 units of packed red blood cells? Select all that apply. A, verify that the ABO and RH of the 2 units are the same. B, infuse a unit of packed red blood cells in less than 4 hours. C, stop the transfusion if a reaction occurs but keep the line open. D, take the vital signs every 15 minutes while the unit is transfusing. What about letter E? Inspect the blood bag for leaks, abnormal color, and clots. And lastly, letter F, use a gauge 22 catheter for optimal flow and for a blood transfusion. What are your answers? Be careful in choosing your answers and also the keywords. Be careful with the keywords in our options. Okay? Don't get lost into the words. I want you to pay attention into the words mixed into the options. Okay? You've got to be careful, guys. Be careful. Okay, I'm seeing ADE, ADE, ABC, DE. We also have ACDE, CDE, BCDE. Okay, let's take a look. Letter A. Let's try to find out if letter A is correct. So it's stated here. Verify that the ABO and RH of the 2 units are the same. Guys, the verification is not on the 2 units, but the verification should be done with the client's compatibility, not just looking into the RH, ABO between the blood product. So this is wrong. Okay, that's why I said be careful. Verify that the ABO and RH are the same, is done with the client, not of the two units. Okay, not with the blood product. You have to check it with the patient's data, not the blood products data. That has to be counter-checked against. What about number 2, or letter B? Infuse a unit of packed red blood cells in less than 4 hours. Yes, the statement said less than 4 hours within the time frame. So this is intended to what? To prevent risk of septicemia. Prevents septicemia. If the blood product has been hanging for more than 4 hours, discard the blood product. Again, if the blood product has been hanging for more than 4 hours, discard. Do not use it. Discard the blood. I'm not saying that we're going to discard like to the garbage. Discarding by sending it to the lab department. Send to the lab if there is a need, or maybe just discard it in a regular biohazard bag. Okay, so we're gonna have to pick this as one of the answers. Again, we're gonna administer it in less than 4 hours or 4 hours. It will prevent the septicemia. Okay, and what do we do with the remaining blood portion? We're not gonna administer it. We're gonna have to dispose of. Letter C. Stop the transfusion if a reaction occurs, but keep the line open. Well, of course, yeah. This is a good intervention. This is going to prevent any more reaction in the patient. We need to stop the blood product right away. Okay. Now, what about letter D? Take vital signs every 15 minutes while the unit is transfusing. Did we say anything about like that earlier? Supposedly, what we will be doing is pre-transfusion vital signs, and then we're going to have to do the vital signs after the first 15 minutes, and then we're going to have to do it every hour, okay? Then after that, we're going to have to transition into the last set of vitals. Again, our vital signs check will be what? The pre-transfusion vital signs, and then we're going to have to do 15 minutes after, and after that we're going to have to do Q1 hour blood pressure vital signs checking, and then post transfusion, not necessarily Q15 minutes. All right, so we're going to eliminate this one. What about letter E? Inspect the blood bag for leaks of normal color and class. Yeah, picking that one as well. And letter F, use a gauge 22. No, we're not going to use this one. This is way too small for a blood product, especially the red blood cells. We should be using a bigger IV catheter, which should be at least 20. Gauge 20, gauge 18 to avoid damage of the red blood cells. So we are eliminating that one. So our answers are, again, letter B. Sorry, I got confused with my checks. Letter B, letter C, letter E. Okay, so those are the correct answer. Letter B, letter C, and letter E. Again, this one right here, take vital signs every 15 minutes while the unit is transfusing. This is going to be an incomplete assessment. We should be doing the vital signs not just when the unit is transfusing. We need to also check after the blood transfusion has been completed and before that, and it has to be in a fashion we're going to have to do the first 15 minutes after the transfusion, and then we're going to have to do hourly, and then finally the last set of vitals. That's fine, AG Ike. No worries. I'm not worried at all. We're going to learn something from here. That's okay. I'm not actually impressed with perfect scores. That's just me. I'm not really impressed with high scores. Yeah. Being an instructor for several years, I'm not impressed with high scores anymore. I'd rather to have a good conversation with that student. Do they really know the mechanisms involved in the nursing care? That's how I want to gauge my patients and my students' understanding. Scores to me doesn't really mean anything. I mean, it could be they could be fortunate just selecting that right answer, but maybe they don't really know the reasoning behind it. That's just me. I don't really trust high scores. Okay, not all the time. Okay, number 5. A client who had received 25 mL of packed red blood cells has low back pain and pruritus. After stopping the infusion, the nurse should take what action next? A client who had received, yeah, there is a partial credit, that's true. A client who had received 25 mL of packed red blood cells has low back pain and pruritus. After stopping the infusion or transfusion, let me correct that, transfusion. The nurse should take what action next? Is it A, administer prescribed antihistamines and aspirin? B, collect blood and urine after samples and send to, what did I say? Collect blood and urine samples and send to the lab. C, administer prescribed diuretics. And D, administer prescribed vasopressors. A client who had received 25 mL of packed red blood cells has low back pain and pruritus. After stopping the transfusion, the nurse should take what action next? Is it A, administer prescribed antihistamine and aspirin? B, collect blood and urine samples and send to the lab? C, administer prescribed diuretics? D, administer prescribed vasopressors? Take your time, guys. Again, we are promoting the course from our website, Stancoast, NCLEX-coaching.com. Please check out also the link below in the description box. We have updated our offerings. We have updated the number of hours for the recorded lectures, and the same thing with the animated videos from 10 hours to 20 hours. And also we have the 3000 NCLEX test questions on top of the 200 NGN test questions, and also the practice tests that we have. So kindly check out our website to know more about us. Okay. Collect blood and urine samples and send to the lab. I'm seeing lots of B this time. That's a good sign. So let's eliminate letter A. What is in letter A? Administer prescribed antihistamine and aspirin. Pruritus. Okay. The administration of the antihistamine and aspirin is going to be needed specific to the antihistamine. This is going to be specific in an allergic reaction. Antihistamine is okay, intended for allergic reaction. Yeah, that's correct. But do you think that aspirin is indicated for the allergic reaction? No. Eliminate that one. That is a wrong answer. And it doesn't, the whole option here, letter A, it doesn't address the need for the confirmation of the patient's reaction. Does not address investigation of reaction, or does not let me change the wording here, does not facilitate investigation of the issue. Okay, it doesn't. You're just treating the patient. Okay, we need to do more than just that one. Okay, what about letter B or letter D? I would do letter D this time. Administer prescribed vasopressors. Do you think that the patient is if there is an indication to give the vasopressors this time? No. We're only going to administer the vasopressors in cases of, or in a case of hypotension. Indicated only in hypotension. Severe hypotension specifically. So this is to be eliminated. What about letter C? Administer prescribed diuretics. Do you think our patient will require diuretics this time? I don't think so. We don't have any clues about fluid volume overload. Not indicated. Scenario does not reflect fluid overload. No signs of overload in the scenario. So we're going to select letter B, which is to collect the urine samples, and we will be sending it to the lab. And the reason for that is to confirm hemolytic transfusion reaction. Confirms hemolytic reaction. Why are we suspecting hemolytic reaction? Take a look into the amount of blood. 25 ml. Little amount of blood has been received. But the patient now is manifesting back pain. Just a little amount is enough to cause a hemolytic reaction. They already have pruritus. So we need to stop the transfusion. And again, the inclusion of this intervention, collection of blood and urine samples, will be needed in order to detect possible hemolytic, or to investigate further the hemolytic reaction. I chose that because I think aspirin can address back pain. Yeah, but aspirin and the antihistamine will not really treat the hemolytic reaction. Take a look into the volume of the blood that the patient received. Very little, but now the patient has developed that low back pain and pruritus. These are your signs of hemolytic reaction. So pick or eliminate those options that will not address the main concern. Okay, we are dealing here with hemolytic reaction. So let me indicate here, hemolytic reaction. So those other interventions like this, antihistamine, will not work. Vasopressors is going to be indicated if we have now some massive hypotension, but this time we don't have that info yet. Diuretics, there's no need. We don't have a clue that the patient has fluid volume overload. Nothing else, but we need to further investigate the source or the reason why the patient has this kind of reaction. And this is going to reflect the hemolysis of the blood in the urine. Okay, let's talk about number 6. A nurse has 2 middle-aged clients who have a prescription to receive a blood transfusion of packed red blood cells at the same time. Oh boy, don't you hate that? 2 middle-aged patients with a prescription of blood transfusion at the same time. Yeah, this would probably be your lucky day if this will be your 2 patients, right? This is a bit scary. Yeah. This would really concern me if I'm the nurse. I'll probably be so grumpy this day. I'm going to be on high alert, especially that I have to deal with 2 blood transfusions. The first client's blood pressure dropped from, let's tackle here this one. First patient. It stated that the first patient's blood pressure dropped from the pre-op value of 122, oh, thank you, AJ, over 80, and then to a post-op value of 102 over 50. I think you are, now this is the reality, AGI. Remember about that question you asked me regarding the blood pressure of a post-op patient of 100 over 50? So this is it, right? A significant drop in the blood pressure from a systolic of 122 over 80 to 102 over 50. Again, a case-to-case scenario. So let's move forward here. The second client is hospitalized because he developed dehydration and anemia following pneumonia. After checking the patency of their IV lines and vital signs, what should the nurse do next? Are you going to A, call for both clients' blood transfusions at the same time? So what it means really is you're going to have to get somebody to grab the blood products at the same time. That's what it meant. Letter B, ask another nurse to verify the compatibility of both units at the same time. Or you're going to do letter C, call for and hang the first client's blood transfusion. Or letter D, ask another nurse to call for and hang the blood for the second client. Yeah. What would be your answer? So I'm seeing letter C's from Boss Babe and Marie Fleur and Mary. Okay. Let me just put the answer here real quick so we don't get lost. The answer to this question is letter what? Letter C. Okay. Before we're going to give the rationale, let me explain first the letter D. I like to eliminate those distractors first. Always. I always do that. Let me start with letter D. Ask another nurse to call for and hang the blood for the second client. Well, that is incorrect. Why? Your patient, the second client, remember about the scenario for the second client. What did it say? The second client is hospitalized because of he developed dehydration and anemia following pneumonia. Okay? Would this justify the urgency of the administration to the second client? What do you think? Is there a prioritization? Is the prioritization correct this time when you are allowing this nurse to do the blood transfusion for the second client? This is incorrect. I know that the patient was admitted for dehydration anemia, but this patient is actually, I would say, much more stable compared to patient 1. Much more stable than patient number 1. So this is a prioritization question with a twist. Much more stable than patient number 1. So the transfusion can wait for this patient, but the transfusion can wait for a second patient, but should be administered to the first one. That is why this is wrong. The priority should be the first patient. Now, what about letter A? Call for both clients' blood transfusions at the same time. Call for? This is basically, it simply means that you're actually calling or simultaneously initiating the transfusion for both the clients, taking the blood products at the same time, and also simulating starting the transfusion at the same time. This is incorrect, guys. This is very unsafe practice. You should not do this. Simultaneous. Whoops. Simultaneous transfusions will allow for more errors, okay? More errors to occur. This is not a best practice. Never do this, guys. This can increase more errors. And also, this is going to be challenging, especially when you are going to monitor the two patients. You just can't. You need to take care of the patient one at a time, not at the same time. So eliminate letter A. What about letter B? Ask another nurse to verify the compatibility of both units at the same time. Oh boy, this is not a good practice as well. You should have another nurse verify the compatibility of both units simultaneously. Both units cannot be done by just one nurse. There should be two nurses doing this. This is wrong. All right? There should be two nurses doing the verification. Like I've said earlier, they should do it independently. Okay? Checking into the blood product, checking into the order, checking into the, what else? The blood product, the consent, everything should be thoroughly checked by two different nurses. They should do it independently, not just one nurse. So we are going to be left with letter C, call for and hang the first client's blood transfusion. We need to prioritize this patient. And take note of the blood pressure change from 122/80 to 102/50. This is a significant change in the vital signs. Only letter C, guys. Please do that. Okay, so letter C is the correct answer. If there is a significant drop in the blood pressure, significant BP drop, the transfusion should be given for this patient in order to stabilize their condition. Okay, we should do this promptly and should prevent, or it will address the hypotension. Okay, need to address this patient first thing. Okay, I hope that you got all the correct. I mean, did anybody check? Okay, looks like most of you guys have correct answers. Let me have number 7. When a blood transfusion is terminated following a reaction, which action should the nurse take next? Is it A, remove the IV line, B, notify the physician and blood bank, C, open the IV line with normal saline, letter D, send the blood bag and tubing to the blood bank? So the scenario is on a patient following a reaction. Which action should the nurse take next? Is it remove the IV line? Is it B, notify the physician and blood bank? C, open the IV line and normal saline, with normal saline rather? D, send the blood bank and tubing to the blood bag and tubing to the blood bank. That's quite a tongue twister. So make sure you do your diligent task to address this patient's issue. You got to do it in a good fashion, in an order that will not frustrate the medical provider. You should do your independent nursing action. Okay? So what would be the best answer? Very good. I'm seeing letter C's. That is the correct answer, guys. Very good. That is the correct answer. Open the IV line with normal saline. Okay. You're going to do the notification to the medical provider once you have started the IV saline. Okay, that would be the next step. So let's start with letter A. Remove the IV line. No, there's no need to remove the IV line. Do not discontinue IV lines. Let me just simplify, IV access rather. You will need the IV access to deliver possible emergency medications, or you will need that to infuse the IV fluid as well, the normal saline. What about letter D? Send the blood bag and tubing to the blood bank. What do you think about that? Are you supposed to do this first thing before stabilizing the patient? No. Stabilize the patient first. Our priority is on the patient who has the allergic reaction. We want to make sure that they have the IV line open and make sure that we have the normal saline infusing. We can do this after we stabilize the patient. What about letter B? Notify the physician and blood bank. I know they are also important nursing interventions, but this will not take priority in running or opening the IV line and also starting the normal saline. Follows after option C. Okay. Deal with your patient first and then do your notification. Make sure that you tell the doctor about what has happened and also call the blood bank. All right. Always treat your patient first. Whatever that you can do independently, do it. Now let's move on. Number 8. A nurse in the emergency department is caring for a client who fell from a 3rd floor balcony. The client is experiencing hypovolemic shock. The nurse anticipates that the physician will order which type of blood product for this patient. Is it A, platelets, B, fresh frozen plasma, C, packed red blood cells, D, cryoprecipitate? The scenario states a nurse in the ED is caring for a client who fell from a 3rd floor balcony. The client is experiencing hypovolemic shock. The nurse anticipates that the physician will order which type of blood product for this client. Is it A, platelets, B, fresh frozen plasma, C, packed red blood cells, D, cryoprecipitate? Okie dokie. I'm seeing letter C's. Very good, guys. That is the correct answer. Our patient is symptomatic, right? After that after that fall, the patient is probably bleeding out and causing hypovolemia. Yeah, significant bleeding. The patient should not be having a hypovolemia if they're not bleeding. So we're going to have to stabilize the patient's circulating fluid volume by giving them the appropriate blood product, right? So what do you think would deal with that one? We're going to give them the packed red blood cells. This will stabilize the patient's circulating blood volume. Okay, so this is the correct answer. What about letter A, platelets? This is going to be indicated only if there is thrombocytopenia. For thrombocytopenia, used for thrombocytopenia. What about fresh frozen plasma? This is for the replacement of the clotting factors. Replaces clotting factors. There's no indication that the patient is running out of the clotting factors. There's no known deficiency in the clotting factors. We're not going to do that. What about letter D, cryoprecipitate? This is also incorrect. Only intended for clotting deficiencies. Used for clotting deficiencies. So choosing the 4 different blood products there's nothing else but the packed red blood cells. I know we can do some more than just packed red blood cells. We can also give them IV fluids together if appropriate. We can do that. But in this scenario, we're only limited about this question asking on selecting which blood product. I know we can do some more interventions other than just packed red blood cells. But here, we're limited to this question, just choosing which blood product is appropriate. Alrighty. So we will need to know really what the indications of each blood product so we can appropriately administer them. Okay. So we need to do that kind of like review. Hey, is this appropriate for this condition? If not, then don't do that. Okay, number 9. The nurse is caring for a client who has received 3 units of PRBCs and is now demonstrating signs of circulatory overload. Which intervention should the nurse implement first? Is it A, administer oxygen via nasal cannula, B, place the client in a supine position, C, administer diuretics as prescribed, and D, discontinue the blood transfusion? The nurse is caring for a client who has received 3 units. Yeah, this is very common, guys. 3 units is a common administration of packed red blood cells, especially for those with severe hemoglobin, low hemoglobin. So now the patient is manifesting signs of overload. So what you would do here? What would you do? Are you going to administer oxygen first via nasal cannula, or are you going to place the patient at supine? Or are you going to administer diuretic as prescribed? Or are you going to do the discontinuation of the blood transfusion? Remember about the table that I showed you earlier? Did you notice a pattern in how we are going to implement our nursing action? Do you remember about the sequence? Let me show you. Circulatory overload. Right? See the pattern here? What should I do? Use your... Okay, we'll talk about that. Hang on a sec. Let me finish this one. So you'll see a pattern with the reactions. Most of those are stop the transfusion, really. I mean, you're going to have to prioritize the stopping of the transfusion. Don't forget that, please. So where are we? Okay, question number 9. So the correct answer here is discontinue the blood transfusion. You should do that first things first, because most oftentimes the diuretics will not be ordered ahead of time. The diuretics can only be available only if we are going to notify the medical provider of the allergic, or the, not allergic, but fluid overload. Okay, rarely that you will have the diuretic available for this patient with a circulatory overload. Most often it will not. There are some doctors that would give PRN orders in case of fluid overload, or let's say something like that. They're good in giving those orders ahead of time, but again, it will not be safe for most nurses, because most of the times this is somewhat kind of like overused. So without critical judgment, they're giving the medication way too ahead. I mean, yeah, this can also lead to some more problems. So basically, the call for a diuretic medication should happen only if the patient is symptomatic, okay? You will not see this in the real setting, that there's going to be diuretic available in the orders. No, you will not expect that one. So you're going to have to discontinue the transfusion, notify the medical provider about that. Hey, doctor, my patient developed this signs of pulmonary edema. Now he's coughing, productive cough. He's now dyspneic, blood pressure is skyrocketing, his heart rate is elevated, he's now tachypnic, his oxygen level is 86% on room air. We started him on 2 liters right now, slightly improved to 92%. So at that time, as soon as the doctor knows what is going on, maybe they're going to order the Lasix, diuretic injection, maybe another testing, maybe chest x-ray, so to follow up the pulmonary edema. So the fashion or the sequencing of the intervention here is very important. Again, we're going to have to discontinue the blood transfusion first, always. Okay. Now, letter A, administer oxygen via nasal cannula. Do you prioritize this one before discontinuing? I don't think so would be appropriate. So we're gonna, oh, sorry. Why did I discontinue? Mark X. Hang on. Let me change that to a check sign. This is a good intervention. Wait a minute. This is correct. Correct. Okay. Priority nursing action. Okay. Followed by notifying. Yes, that's what it is. The question says received means he already is through 3 units. Yeah, that's why he developed the circulatory overload. Circulatory overload has received. Okay. Okay. It doesn't mean Ash Joseph has received, hang on a sec, who has received 3 units. It doesn't mean that the 3rd unit has been completed. Received means it's infusing, right? I mean, it could be that the 1st, 2nd is already done, but maybe the 3rd is considered as, like, let's say, received, but still going on, okay? It could be in that context, right? That the patient has received the 3rd unit, but currently transfusing, okay? It could mean like that, in that context. So it doesn't mean that it has already been continued, like completed. No. What this statement is, the situation is actually pertaining to at least the 3rd unit infusing still. It doesn't mean about a completed blood transfusion. Okay, so if we're going to put that in that context, please, if you are not giving the severity of signs and symptoms, how would you know or stop? Okay. Signs of circulatory overload, this is going to be a cluster. Guys, if you're going to have to read through the scenario, circulatory overload, it will comprise all of those manifestations. Shortness of breath, it could be hypoxemia, elevation of the, what do you call this? Rapid heart rate, rapid breathing. Circulatory overload can comprise any of those manifestations, okay? So if you're going to select any of these options, you are limited to discontinue, administer diuretics, place the client in a supine position, nothing else. I know that there's some more intervention. It could be slowing, okay? But here, you're only limited to what is given in the scenario, and you need to select what could be the best treatment for this patient. I know you are so ideal with selecting those interventions, but again, take a look into the circulatory overload. This is going to be a cluster of manifestations, all right? Don't limit, the overload itself. You can think of the mild, it could be the severe, but take note of the 3 units, right? The 3 units could be costing a lot more to this patient. So if we are looking at, let's say, a volume of 600, maybe close to 800 mLs for this patient, this could be a significant amount for this particular patient. That's why there is such a development of circulation overload. So again, our best answer here would be to discontinue the blood transfusion. In the context of this question, it doesn't mean that it has been completed, but it is given, all right? It is given. When you are starting a transfusion, it's already considered given, but it is continuing, all right? That's the context of this question. All righty, letter C is going to be a second action for this patient. Of course, placing the patient in a supine position would not help maximizing their breathing. Administering oxygen via nasal cannula can follow after we stop the blood transfusion. Okay, let's talk about number 10. A 78-year-old woman with chronic renal failure and anemia is scheduled to receive erythropoietin therapy. Her current hemoglobin level is 7.5 grams per deciliter and hematocrit of 24%. And she reports fatigue and dyspnea on exertion. Which additional medication should the nurse anticipate administering to enhance the effectiveness of erythropoietin therapy? So this is very close to the topic, closely associated with the topic that we talked on the other day. Okay, a blood transfusion, but now with a mix of erythropoietin. So the question states, which additional medication should the nurse anticipate administering to enhance the effectiveness of erythropoietin therapy? Would that be folic acid? Would that be vitamin B12, iron supplements, or vitamin C? Let's eliminate letter D first. Let's try if I can eliminate letter D. Vitamin C. Will this enhance the effectiveness of erythropoietin therapy? Well, we know that vitamin C can enhance iron absorption. We know that, right? Especially if we are giving the iron via oral route. Enhances iron oral route absorption. Okay, but cannot enhance erythropoietin therapy. Does not enhance erythropoietin. Okay, what about letter B? Vitamin B12, which is the cobalamin, cyanocobalamin, which is going to help with the blood cell production. Remember about the B12? Can help produce the red blood cell. Helps produce maturation of the red blood cells, but it is not known to enhance the erythropoietin therapy. Remember about the, it has to some degree, but it's not really going to be the primary drug for this problem. Okay, so what can cause more of the red blood cell production? To some degree, it can help, but not really for letter B12 or vitamin B12. Let's see letter A. Folic acid. Vitamin B9 is also important in the production and maturation, but is not going to be effective in enhancing the erythropoietin therapy as well. It isn't. It is not known. So same thing with letter B. Not directly related to erythropoietin therapy. To some degree, again, it can help the maturation of the red blood cells, but not the main drug to help. Not directed to what? Help or enhance erythropoietin, or let's just say erythropoiesis. So we have the last one, which is basically the iron supplement. Remember about the role of the iron. This is going to be necessary for the production of the hemoglobin and also the red blood cells. So here, the erythropoietin therapy is going to be much more enhanced because of the adequate iron levels. Adequate iron levels enhances erythropoietin therapy. So that's the reason our iron supplement is going to have that, what do you call this? Synergistic effect to the erythropoietin hormone. Okay, again, if there is adequate amount of iron levels in the bloodstream, it will help in the production of the red blood cells, of course, with the presence of, it will aid in the production of the red blood cells and also with the hemoglobin levels. Okay, number 11, let's go to this question. A 45-year-old male with a history of GI bleed is admitted with a hemoglobin of 6.8, hematocrit of 20%. He is to receive a blood transfusion. What should the nurse monitor for during the transfusion? The question states, a 45-year-old male with a history of gastrointestinal bleed is admitted with a hemoglobin level of 6.8 grams per DL and hematocrit of 20%. He is to receive a blood transfusion. What should the nurse monitor for during the transfusion? Is it A, fever, chills, back pain, B, bradycardia, hypotension, C, hypertension and headache, and D, hyperglycemia and polyuria? Your patient's hemoglobin and hematocrit levels are severely low, so your patient is going to receive the blood transfusion. So what you should monitor here, guys, are you going to do letter A? Are you going to select letter B? Or is it C or D? Now remember about the common transfusion reactions. Please don't forget about that. Common transfusion reaction. Look for the common reactions. And you're correct. Very good. You should be selecting letter A. This is the one. So these are the signs of the transfusion reactions. Now take a look into the bradycardia. Most often, the patient will end up with tachycardia, not bradycardia. The hypotension is check, yeah, but not bradycardia. Most cases, as we have seen into the different complications or reaction, there is tachycardia, not bradycardia. Let's take a look in letter C, hypertension and headache. Do you think that these are very common? No, not really common manifestations of transfusion reactions. Most often we will see the chills, the fever, and the back pain. And of course, the hypertension, not so much. The hypertension can be seen in what? The overload, right? Do we see the overload? Let me just take a look real quick. Just want to take a look. Was it overload there? Yeah, I didn't list any hypotension here, but we're going to actually add the hypertension over here. But in the other cases, we don't see the hypertension most often. Let's take a look into the other ones. Hypotension mostly. So for the circulatory overload, you're going to expect hypertension. Okay. Let me go back to that last screen. So there is going to be hypertension in fluid overload. But in the other cases, we will see hypotension. So we're going to look for the most common blood transfusion reaction. So we are eliminating that one. What about letter D? Hyperglycemia. Did we mention about hyperglycemia as one of those reactions? No, they are not related to the blood transfusion reaction. Eliminating that one. Not associated with any of blood transfusion reaction. Not. Okay, not even a polyuria. So our patient here would be possibly manifesting letter A, nothing else. Fever, chills, and back pain. Again, those are the most common clinical features of the blood transfusion. Let's take a look on 12. A 30-year-old female with idiopathic thrombocytopenic purpura, or ITP, is receiving platelet transfusion. Before starting the transfusion, what action is most important for the nurse to take? Is it A, check the client's temperature, B, verify the platelet count, C, check the client's blood pressure, and D, verify the client's identity and blood type? Another question. It states a 30-year-old female with ITP is receiving platelet transfusion. Before starting the transfusion, what action is most important for the nurse to take? Is it A, check the client's temperature, B, verify the platelet count, C, check the client's blood pressure, and letter D, verify the client's identity and blood type? What would be that pre-procedure check? What do you think would be that very critical pre-procedure check before administering the blood? Remember that we are going to deal with a live patient, not a mannequin. Just kidding. Yes, guys, of course. Letter D, verify the client's identity and blood type. Okay, that is the priority nursing action. Identifying the client's identity is the foremost and very crucial nursing action that you should be doing. Okay, this is the most crucial nursing action. You've got to do that in order to give the correct blood product and also to administer the blood product to the correct patient. Nothing else. That's why we are going to do this extensively. For me, in my practice, I have to repeat checking the patient 3 times. I just don't rely on one batch of check. When I am working with another nurse, before I administer the blood product, I just don't go just by once checking, let's say checking the order. No, I go by 3 times. I know that it's kind of like an overkill, but it saves so many of my patients. So I would stick to that practice. I would not really recommend that to you, but again, checking the verification of a patient can really save lives. All right, that is very important. What about checking the temperature? I know it's important, but if we're just checking the temperature and not really doing the first priority, then you're also possibly gonna identify, or maybe you are giving the wrong blood product to the wrong patient. So this is not gonna take priority. Platelet count, it's also important, but it's not as crucial compared to verifying the correct patient, verifying the correct blood product. Checking the client's blood pressure, it's the same level as checking the temperature, pre-vital signs check, but it doesn't replace the proper identification of our patient and the blood product. Nothing else. Okay, let's move forward with number 13. A 65-year-old man with a history of chronic obstructive pulmonary disease, scheduled for surgery. He has been prescribed pre-op blood transfusions to improve his oxygen carrying capacity. What should the nurse monitor to ensure the patient does not develop transfusion-associated circulatory overload or TACO? Is it A, heart rate and respiratory rate, B, urine output and color, C, blood pressure and pulse pressure, D, lung sounds and oxygen saturation? Take your pick. Our patient has a history of COPD and is scheduled to have surgical procedure and now has an order for a pre-op blood transfusion to improve his oxygen carrying capacity. Well, of course, maybe the patient has significant drop, right, in their hemoglobin. So what you should monitor? What you should monitor to ensure the patient does not develop transfusion-associated circulatory overload. It's a close call between two options. Remember that our patient will be manifesting what? Respiratory signs and symptoms. What you should monitor here. I know these two are very close to each other, but we are focusing into one system. What system do you have to dedicate your assessment on? Okay, let's eliminate letter A first. What is in letter A? Heart rate and respiratory rate. They are also going to be indicators in a patient with TACO, right? They can be elevated, but they are not going to be the primary indicators of TACO. Not primary indicators of TACO. Okay? They can be elevated. I did not say that they are not going to be affected. Yes, they can. You will expect elevation of the heart rate, elevation of the respiratory rate. But these are not the primary indicators. These are secondary indicators of TACO. What about letter B? Urine output and color. The urine output is not directly associated with the TACO. So basically, you are diverting your assessment into the urine output, and we know that the manifestations will be pulmonary, so you're missing out so much of the manifestations here if you're going to prioritize this one. So we're going to eliminate that one. What about letter C? Blood pressure and pulse pressure. I know they can also be good indicators in the TACO. If there is going to be an overload, fluid overload because of the blood transfusion, I know the blood pressure can be elevated. It can cause hypertension, but these are not the primary indicators. Not primary indicators. And why do we have to select letter D? Lung sounds and oxygen saturation. Remember that we can only capture about TRALI's manifestation if you are directly assessing the lung sounds. When you're going to hear those crackles, and if the patient's saturation goes low, yeah, these are the main indicators: lung sounds, crackles, pulmonary edema. Your manifestations will be more of a respiratory. So focus into the respiratory system assessment, okay? So this is our answer. These are the primary manifestations in a case of TACO. Oxygenation, guys. So patients breathing and circulation. The patient saturation possibly could be lower, so that is a high priority. Breathing with the lung sounds, especially with the crackles, pulmonary edema, that is an issue as well. All right. And again, focus into the respiratory system. The blood pressure and also the pulse pressure increase are just secondary manifestations, so don't get fooled. Let's move on to number 14. A 38-year-old woman with a history of multiple blood transfusions presents with jaundice and fatigue. Her lab results show increased bilirubin levels and decreased hemoglobin. What complication of transfusion should the nurse suspect? Is it A, TRALI, B, delayed hemolytic transfusion reaction, B, or C rather, febrile non-hemolytic transfusion reaction, or letter D, transfusion-associated circulatory overload, or the TACO? So it said here, multiple blood transfusion presents with jaundice and fatigue. Lab results show increased bilirubin levels and decreased hemoglobin. So you are asked about identifying the complication of the transfusion that you are suspecting. Okay, is it TRALI? Is it delayed hemolytic reaction? Or is it the febrile hemolytic or febrile non-hemolytic? Take note of the term febrile non-hemolytic. This is the TACO, overload. Here is lung injury. And this is hemolytic. Take note of the clues in the situation. I am seeing B from Javier. This is the first time I've seen your name. Welcome to the class. Boss Babe answered B. Mary answered D. Vinus Ridderin is B. Ruth answered D. Silij Paulo, D. Is it how you say your name? Siligi or Silij? Melrose answered D. I'm not quite sure if this is on the same question. So let's try to eliminate first the option starting with letter D. Let's start with letter A this time. Option A, transfusion-related acute lung injury or TRALI. So take a look into the manifestations of the scenario. So let's gather those before we will decide. What are those? Jaundice. There is also what? Increased bilirubin, decreased hemoglobin. So what do you think about this jaundice? Why the patient is having jaundice? Well, when you are suspecting a kind of a hemolytic reaction, what do you think is going on in the red blood cells? There is what? Breakdown of RBC. And why there is a breakdown of the RBC? Possibly because of the ABO incompatibility. ABO-RH incompatibility. When the patient is given the wrong blood product, wrong blood group and also wrong RH, this will cause hemolysis. It simply means that the red blood cells will break down, and it can lead to the release of or increase in bilirubin. Increases bilirubin in the circulation, in the blood, I should say. And what else? The patient will have that jaundice, okay? They will manifest yellowing of the skin because of the pigment found in the bilirubin, okay? The patient will become yellowish in their sclera. Their oral mucosa will be yellowish. For the African Americans, they will have that kind of like yellowish hue into their inner aspect, the anterior portion of their skin. It also, what else? The nail beds, pay attention to the color of the nail beds. There will be some kind of like discoloration there. Sclera, what else? The conjunctiva, take a look into those as well. And so what we're gonna expect are the following again: increased bilirubin, jaundice, and of course, what? Fatigue, because of the drop in the hemoglobin. Why is the hemoglobin going down? Because of the hemolysis. So we don't have any other answer but letter B. If you selected letter A, the TRALI, remember that the TRALI is sudden, okay? TRALI is sudden occurrence. It is abrupt. It can also lead to the ARDS, okay? Not jaundice. No jaundice in TRALI. So we are eliminating letter A. What about letter C? Febrile non-hemolytic transfusion reaction. Well, if the patient only has the febrile non-hemolytic reaction, then there should be no jaundice, no increase in bilirubin. So let me just write that out. Febrile reaction. So there should be no jaundice, no elevation of bilirubin. Okay, the patient will manifest primarily the fever and the chills, but none of the bilirubin increase, none of the jaundice. If you had answered letter D, transfusion-associated circulatory overload, it doesn't quite match to the descriptions or the manifestations mentioned in the scenario, okay? It doesn't. There's no jaundice, there's no increase in the bilirubin in a case of a TACO, circulatory overload, none. So we are gonna select letter B as the correct option. Very good, guys, very good. Let's take a look at number 15. A nurse is preparing to administer a unit of PRBC to a client with a hemoglobin of 8.2. Which of the following actions should the nurse take first? Is it A, prime the IV line with a dextrose 5% in water? B, obtain the client's vital signs? C, check the expiration date on the blood? Oh, thank you, Javier. Thank you. You're welcome. And of course, if you just joined us, please review the recorded videos that we have in the previous live sessions. I'll send the link in our chat box if you haven't located that one yet. Okay, so what will you do first for this patient? Are you going to prime the IV line with 5% dextrose, water? Are you going to obtain the client's vital signs, or are you going to check the expiration date on the blood unit? And D, ensure the client has signed the consent form. What should the nurse take? Which of the following action that should take first? All right. I would immediately eliminate letter A. Why? Using dextrose water is a big no. No way, Jose. Never use other IV fluids other than the normal saline. Always use 0.9% NaCl IV. Never use dextrose. It can cause hemolysis, clumping of the red blood cells. Okay, what about letter B? Obtain the client's vital signs. Before you can obtain the patient's vital signs and administer the blood, there's a much more priority here. What is it? Well, of course, you got to get the patient's consent. First things first. Remember about what I emphasized earlier about obtaining the informed consent? Yeah. The risks and the benefits is included in the informed consent. The indication of blood transfusion is included there. All right. So we need to make sure that the patient has understood and signed the consent because of a preliminary explanation, such as the risk and the benefits and the indication of the blood transfusion. This is fundamental in the blood transfusion. Okay, always do that first. I know checking the expiration date of the blood unit is also important, but this will not precede the checking or getting the patient's consent. All right, it will follow, can follow. All right, follows after obtaining consent. All right, the same thing with vital signs. Yeah, you can do that as soon as you're ready to administer the blood product, but you have to confirm first. Make sure that the patient has the consent. Yeah, I'm so anal, guys. In the real setting, guys, when you are transfusing a patient, in most hospital settings, we are going to have them sign the consent, right? And the paperwork basically can be in a triplicate. In some hospitals, it can be a triplicate, or there is a duplicate copy. The first copy will be placed in the medical record, and the patient will also get the second copy, which is the yellow page, right? So this will be their evidence that they have indeed signed the consent for the blood transfusion, but I don't usually rely on the yellow copy. When I have to administer the blood product, I always grab the main chart of the patient, okay? Always check for that consent, bring that with you in the patient room to have a physical view of that consent, okay? Make sure that it's dated, it is signed, it is witnessed by the nurse, okay? The consent should be current, signed by the patient, and also dated, and also witnessed. It's just not about the signature of the patient. Make sure that it's signed by the patient or maybe the medical proxy if the patient is not able to do that. And then make sure there is the date when the consent was signed, and it should be witnessed. Okay? So make sure that you do this before transfusing any blood product. Okay? Always do that. Safeguard yourself and the patient. Alrighty. Let's tackle number 16. 50-year-old with chronic liver disease is receiving fresh frozen plasma due to coagulopathy. What is the most important nursing action when administering the fresh frozen plasma? Is it A, administer the FFP as rapidly as possible? B, monitor the client for signs of transfusion reaction? C, encourage the client to drink plenty of fluids? And D, assess the client's electrolyte levels. Fresh frozen plasma due to coagulopathy. What is the most important nursing action when administering FFP? Let's try to eliminate the letter D. Assess the client's electrolyte levels. What do you think about that? Do you think that we are going to have to be worried about the electrolyte levels when administering the FFP? Do we have to? Well, it's not closely going to influence each other. So we're eliminating that one. Electrolyte levels, no, not closely associated, will not influence each other. Okay, no influence between the two. What about letter C? Encourage the client to drink plenty of fluids. Do we have to do that? No, there's not, so no recommendation really identified regarding increasing their fluid intake. We don't have that. So this is just a buzzword. What about letter A? Administer the FFP as rapidly as possible. As rapidly as possible? Do we have to do that like within 5 minutes, 10 minutes? That's not really a safe statement, okay? We should have a controlled rate for the administration of the FFP. Should have a controlled rate. As rapidly as possible is very unsafe. There should be a guideline that must be followed regarding the administration rate. Eliminate that one. So we are out with letter B. Monitor the client for signs of transfusion reaction. Remember, guys, that the FFP still need to be, we still need to monitor our patient critically because there is a high chance that there is going to be a reaction. Reaction is still high in the FFP transfusion. Okay. We have to check the first 15 minutes. Yes, Javier, very good. First 15 to 30 minutes, you gotta stay with the patient. Keep asking the patient, are they doing okay? Are you having any new back pain? Are you feeling itchy? Do you feel warm? Do you feel like different now than the last 15 minutes ago? So keep assessing your patient, ask them, all right? So don't be kind of secretive about the asking the question. You really need to educate the patient. Hey, I just want to make sure that we are on the same page this time. I just want to make sure that you are safe while I am administering the blood product. So please let me know if you feel anything weird, if you feel itchy, if you have a new onset of back pain, if you feel any chest pain or shortness of breath, pruritus, or any of those, ask those, because our patient will be able to, hey, yeah, I think I am having the reaction right now, like what you have said. So they will report to you as soon as they are aware what to report, okay? So let's select letter B. Okay, what about number 17? A client with severe anemia is to receive a transfusion of packed red blood cells, and the nurse is aware that transfusion reactions are most likely to occur within the first 15 minutes. What initial assessment is priority during this time? Is it checking the client's blood pressure every 5 minutes? Or is it B, observing the client for signs of urticaria or pruritus? C, monitoring the client for changes in oxygen saturation? Or D, staying with the client to monitor for any adverse reactions? I think this question is given. It's like a bonus. What initial assessment is a priority during this time? Are you going to do A, which is checking the blood pressure every 5 minutes? Did we say every 5 minutes in our lecture earlier? It's not necessary. Our parameter is basically on the client status, not just on the blood pressure frequency. That is way too much every 5 minutes. Not just blood pressure, okay? Okay, let me clarify here, guys. Patient severe anemia. The nurse is aware that transfusion reactions are more likely to occur within the first 15 minutes. Do you think that the blood pressure can capture the frequency of the blood pressure measurement is enough to capture the other manifestations? The answer is no. The blood pressure? There's more than just the blood pressure. Okay. There are more signs and symptoms than just the blood pressure changes. Okay? You will not be able to capture the other manifestations if you're going to solely depend your assessment on the blood pressure every 5 minutes. And the 5 minutes is an overkill. Like I've said, you're only going to do the pre-assessment blood pressure check 15 minutes after the initiation of the blood transfusion and every hour after the initiation of the blood transfusion and then after the blood transfusion has been completed. Okay? So again, the blood pressure will not capture all the other signs and symptoms. We are marking this as wrong. Observing the client for signs of urticaria and pruritus. It seems to be okay. Yeah. But our manifestations are not just limited onto the hives or the urticaria or the pruritus. There are some more manifestations that we need to pay attention. Okay, so the same with letter A. This is limited assessment. We are looking for that answer that can have that umbrella effect. Okay, what about letter C? Monitoring the client for changes in oxygen saturation. The same thing. It is limited assessment. And again, what initial assessment is priority? This can comprise everything here. Staying with the client to monitor for any adverse reactions. The statement itself doesn't seem like similar to the ABC, but again, this can cause that umbrella effect. All right? It's not stated like, hey, I'm going to check for this and that. It isn't. It's weirdly stated. But again, the act of the nurse here can capture so many of the manifestations in any kind of blood transfusion reaction. And this is what we are looking for in this question. All right, this is the priority. All right, so don't just kind of like get stuck to that kind of like very archaic or let's say standardized kind of statement. Sometimes other options can be stated weirdly, but actually it can answer the question. Yeah, these are those kind of statements or options that can be very difficult to identify sometimes, but you have to identify it no matter what. All right, let's see if this is going to be the last one. Yes, it is the last test question of the day, so I hope that you're learning today. And we will be having another topic tomorrow. We will be talking about shock, and so I'm expecting you to be with me during that session. There's so much to learn about shock. That is another concept that is going to be seen in the NCLEX test question. So again, I appreciate your attendance today, and I hope that you are learning, and I hope that you you have some more enlightenment with the discussion. So that's it. You take care, everyone. Okay, bye-bye. Oh, before I'm gonna leave, actually, let me send the link for the live session in the chat box. And I will also send the information. Actually, I think I have the information already. So here is the website that we have. That's www.stancoast-NCLEX-coaching.com. We are encouraging you to enroll in our NCLEX review course, which is going to be available for the entire 6 months. And we have updated our course library. We have 20 hours now of the animated videos on demand, plus the 200 hours of recorded lectures, plus the 3,000 NCLEX test questions on top of the 200 NGN test questions. And we also have the other study materials, the flip books, OD books, and this is something that you can enjoy for the entire 6 months. And again, our goal here is to boost your confidence, and we are going to support you with your learning as well. And again, please don't forget to hit the like and subscribe button and share this to your friends who are reviewing. I hope that you found this video helpful. So again, don't forget to hit the like and subscribe button. Again, thank you so much. Have a great day, have a great night, and take care. Oh, let me just send this link. Okay. Copy. And thank you, everyone. Bye-bye.